we are going to get started with the afternoon session of the meeting. As you see, Nic has a fascinating background, certainly very well grounded in policy. So she might speak to, or we might invite her to comment on some policy aspects if she's willing to speak on those. But then, of course, for today's session, she's going to share with us her empirical study and some findings, which is fascinating, and perhaps to speak a bit about the situation in New Zealand on surveillance and some of the trajectories of developments or challenges ahead. So with this, welcome, Nic.
Thank you.
Forum is yours.
And thank you very much, Calvin, for the opportunity. Mine's a bit of a different take on these subjects. I'm a sociologist by trade, so I've been involved in a bigger project that Mike talked about earlier, and we collected a lot of qualitative data with some stakeholders over the last few years, and this is just focusing in on a tiny bit of that, which is about the companion animal sector and monitoring antimicrobial use and resistance in that sector, which is a sector that seems to be often overlooked in these conversations. So you've seen this disclosure before by Mike, so we'll just not worry about that. And we're all aware of the problem, and we're aware of the fact that measures to decrease AMR risk have basically been focused on better stewardship of antimicrobials in a lot of cases. And that's one way of tackling the problem, but this project that we've been working on, they were trying to think of another tool to add to the toolbox, introducing an antimicrobial that was just going to be used in animals and not in people. And we can rush through that, right. So in New Zealand, as you might have seen from the maps presented earlier, there was a lovely map of the world there about how everyone was monitoring their antimicrobial use, and then there was New Zealand, and we were one of the countries that was not coloured in, because despite the fact that we are a very animal-based country productively, we don't really seem to have made big steps in our monitoring program. And the human side, yes, that's monitored. We have a lot of data about that. But in the animal side, not so much. It is worth noting, though, that in our animal production sector, we're actually a very low user of antimicrobials compared to other places in the world. We have an outdoor farming system largely. We do have indoor farming for chickens and pork, and they have traditionally been high users, but it's quite a different setup. But we are a high user of human antimicrobials, unusually. So why does this data matter? Why do we want to gather any data about companion animals? I mean, they're just pets. But as this person from the New Zealand Veterinarian Association said, the volume might be in the production centre around the world, but we live with our companion animals. We let them lick us. Well, some of us let them lick us. I'm not a big fan myself. We sleep with our pets. Pets are becoming more and more integrated into our everyday lives. And I've seen that in Hong Kong here. I've seen people, we don't do this in New Zealand, I've seen people with their dogs in baby buggies. They seem to have very close relationships with these companion animals. And we do love our pets in New Zealand. We have a lot of pets, 64% estimated of the households. We're only just right behind the USA. It's mostly cats and dogs. And most of us regard their pets to be family members. They're not just an animal you have around, they're actually part of the family. So how is the monitoring of both usage and resistance working or not working at the moment? So this vet talks about how at the moment, if he wants or she wants to find out what's going on, if someone's got this, if this is a resistant bug, they would have to ring up all of these different labs in New Zealand and then get those labs to send them the individual data. There is no way that they can get their hands on that data from an aggregated source. So talking about skin culture, some vets culture bugs from skin, a lot don't bother, and we'll get onto that later. There's no overarching system that monitors this or encourages this. It's very much an ad hoc basis, what the vet wants to do. So we do that for humans, but again, we have the human system and we have the animal system, which is sort of somewhere down here. It's not treated on that same way. So this person said that at the minimum, having some kind of communication between the labs, it does seem like quite a minimum requirement, would be great, because at the moment it's just a grab bag of different data. So why is it like that? Well, we all know data needs dollars, but no one wants to pay. So at the moment, there is no government funding for this. So this person said there is for notifiable diseases, for example, that is funded, but when it comes to AMR, that seems to have just fallen down the cracks. And this person felt that perhaps if we based a monitoring system on the way we do for notifiable diseases, that would be a relatively inexpensive way to do it, but even that takes resource. And we've been working with an AMR working group member, this is for animal health in New Zealand, and they've done a lot of work on this, and they did actually put forward proposals to the ministry, various ministries actually, from an animal health perspective, but again, there was no money and there was no real political will to follow that. So the last time they went to the government, they said, oh yeah, well, we could probably do that. Things changed, governments changed, trends changed, AMR's sort of gone out of fashion. Methanogens are what are being funded in New Zealand at the moment. If you've got an anti-methanogen program, you're probably going to get some cash. And AMR does actually just seem to have dropped out of the public consciousness a wee bit and the government consciousness. The other thing that problem we have is a sort of a micro level problem where in New Zealand we have a government funded health system for people. So when I go to the doctor, I pay a small, relatively small subsidised amount. All acute care is covered, it's totally free, antibiotics are free, or there may be a small charge depending on the government. All my testing's free. I can get as many tests as I want, pretty much, and that's all covered by the government. So when I go to my vet, I find it really confronting that they say, well, you know, if you want a blood test, that's going to cost you $100 for your cat. If you want antibiotics, that's going to cost you another $80 or whatever. So when they say, would you like to have this bug cultured up? And they say it's going to cost $180, the clients say, no, what is the value to me of that? You know, why don't you just give an antibiotic? It'll probably work. If it doesn't work, I'll come back. We might talk about it then. But there's really no way of making a person pay for that culture. So a dermatologist said that she worked in the States and they were testing and they found very, very high resistance. So she's a big advocate of bringing it in here. But again, how do you get people to pay for that? So the state she worked in, she said she saw a noticeable change because at one point they did bring in a subsidy system where they were actually subsidising clients so that they were encouraging the vets to test. And that was a very successful initiative. So we also have a little bit of a problem with resistant vets. And I don't mean they're resistant to, well, they might be because they're with animals all the time. But we did talk to some vets who really felt that this wasn't really a problem for them in the companion animal sector. They did just think, they thought this was just a problem for other sectors of animals and for human health, but they didn't feel that companion animal use of antimicrobials was really a big deal in New Zealand. Of course, this is a hard thing to argue for and against because we don't have any numbers, so we don't actually know the scale of the problem. So this person was concerned, he said he would be concerned if he found resistance in his patients that meant that they couldn't be treated, but he didn't see it as something that was going to affect people all that much. The bugs he deals with weren't shared by people, and he wasn't overly concerned about the use generally in companion animals. He also felt that it wasn't really contributing to zoonoses on a big scale. There were other vets who disagreed with this, but this is the people who are actually going to have to put these things in place. So I've covered both attitudes there. Another vet felt that if they were being monitored, well, they already felt that as they were treating animals, they sort of had less social license to be using antimicrobials in the first place compared to people in the human health sector. So this person said he felt that the New Zealand Veterinary Association recommendations to reduce antimicrobials, that had sort of translated to him, and he said a feeling of shame that when he prescribed antimicrobials, he felt that he really had to justify those actions. And he felt that this wasn't the same in the human health area, that his mates who were GPs weren't feeling that same sense of shame. When we talked, I did talk to some doctors about this, and that certainly didn't resonate with them. They felt that they could always justify their use of antimicrobials. They said, we're responsible prescribers. We only prescribe when they're needed. Why would I ever worry about that, basically? Whereas, and I think this speaks to the One Health framing of this, the vets felt that they didn't have quite the same rights to the drugs as human health practitioners did. And so this weighed heavily on them, that maybe they were doing something wrong just by treating animals in the first place, which really conflicts with their belief that animals deserve welfare and just as much access to health as people. So this is another point from the AMR working group. They would love to have this system. They think it's unlikely to happen because of resourcing, but they also think that vets probably will have trouble buying into it and actually giving them the data. Vets make some of their money out of selling drugs, and that's just a commercial reality for them. And the AMR group felt that it would be quite difficult for vets to take part in a program where they were reporting everything. I mean, medical doctors do it, so I don't know if that's a valid concern or not. And it may just be that the vets aren't being made to do it yet, but they certainly had concerns around that. So there was also mention of this lack of a One Health framework, really. So the AMR interest group, originally they were formed in a One Health context, and they were human health and animal health. Of course, the environment still didn't get a look in because that's way out here somewhere, but at least these two groups were together. But sometime 5 or 6 years ago, that sort of just broke down. Human health went back to their human health silo, and the vets remained, or not the vets, animal health people remained in their silo. And they really don't talk to each other anymore, these two working groups. Sometimes they do incidentally because they know each other, because New Zealand's a very small place, but they're not working in partnership under that One Health framework, which was the original aim. So this person says that, for One Health to really work in this monitoring space, everyone has to get together: human health, animal health, and even horticulture, because we do use a lot of antibiotics in our horticulture in New Zealand. We just don't have that at the moment. We talk about One Health because we know about it, but I don't think it's really at the front of people's minds when you think about this monitoring side of things. So this really speaks to the siloing of data. Like, there hasn't been any mention in this of extending the human monitoring program out towards animals. That just doesn't even seem to be part of people's consciousness. They just said, oh, well, that's just for humans, and the animal industry would have to start up their own one if they wanted that. So I've gone a bit fast, I think. So in a slightly concerning conclusion, there is currently no overarching monitoring system for antimicrobial usage across the veterinary section or for monitoring resistance. It's piecemeal, and it isn't meeting any kind of need. There is a lack of political will, and therefore a lack of funding. The data we do have is siloed and difficult to aggregate. And there may be a lack of buy-in to monitoring programs by vets due to a lack of belief that AMR is a problem in pets and concerns about having prescribing practices monitored. It would also place a huge onus on vets themselves, because a lot of these people are in small practices. They're not particularly high resourced. We have a very dire shortage of vets in New Zealand. So even to treat animals, they're already stretched pretty thin. If you're going to add a whole monitoring and data management layer onto that, there actually just isn't the resources there to do that. So this person said, we need better surveillance across all animals. This is just summing up, really, and centralised reporting around this. You know, we don't even have centralized reporting around large numbers of mortality. So we need to do better in that space. And we can. We just need to invest in and actually get that happening. So really, any suggestions would be gratefully received. Yeah.
Thank you so much, Nick. Well, some very insightful findings there. So moving on now to our next presenter. Thank you so much, Nick. Yeah. So we could take the discussions together because they're interlinked. Of course, one of the projects that we're kind of engaged in, right, is to think about our relationship with microbes. So we tend not to think about microbes because we don't see them, or at least we consider them to be the enemy. But of course, microbes tend to be hugely important because there's studies to show that gut microbes in particular are essential to human health. So without gut microbes, there seems to be some evidence that points to these individuals being more prone to certain chronic diseases like diabetes. So it's also for similar reasons that we use these antibiotics for prophylactic purposes, farming, so that we get larger animals. But of course, then these animals also themselves become predisposed to these sort of conditions. I'm very happy to have Professor Yonghui Ma with us today because she's going to speak on a related topic on our link to microbes and why this is important when thinking about human health and how that could perhaps help us think about the AMR challenge, well, in a sense, in relation to ourselves, but also our place in the wider environment. So Yonghui comes to us from Xiamen University, not too far from here. So welcome, Yonghui. Thank you.
It's been such a great honor to be here. I'm Yonghui Ma. I'm from Xiamen University. Previously, I had a background on clinical medicine and a master's degree and a PhD degree on bioethics. Today, I wanted to talk about the relationships of between microbiome science, antibiotic stewardship, and One Health. This is the outline of my presentation. First, I'll give you a brief introduction, and then I will briefly explain how microbiome have a huge impact on the human, animal, and the environmental health. And then, it's been proposed that microbiome science will be need to be considered as a key research priority in One Health. And I will give you a example of fecal microbiota transplantation as a tool for AS. And then we will examine the ethical and governance issues about fecal microbiota transplantation and also the hype of this microbiome science. This morning, a lot of scholars have explained, introduced the One Health to address the challenges at the intersection of human, animal, and the environmental health. One Health approach relies on collaboration across multiple sectors, disciplines, and communities. And we know that microorganisms are widespread in human, animal, and the environment. Therefore, studying the microbiota and the microbiome offers potential solutions to address the One Health issues. And conversely, adopting a One Health perspective can also address outstanding questions related to the microbiome. The microbiome has been a key research priority in the One Health system and provides an important intermediary link in the management of One Health issues. With the development of science and technology, humans have increased their impact on animal and plants, and also extended this impact to previously unaffected environments. Many steady states in the environment gradually break down, and the impact of some unknown viruses is immeasurable. In addition, with increased exploration of the universe, humans may face the risk of physical, chemical, and biological research outside Earth. So research on the microbiome is ongoing, although microbiome modulation strategies such as probiotics, prebiotics, FMT, and phage interventions have been proven to improve the environment and treat human disease effectively. There's a lot of unknown because the data is not sufficient to support this. So Microbiome impact is essential. The new knowledge has led remarkable insights into the fundamental impact that the microbiome have, not just on human health and the entire food system, soil, plants, animal, but also on the planetary health, has generated valuable insights in different food system microbes, including the microbiome of soil, farmed animals, and terrestrial and aquatic ecosystem. This is a picture I think is very important and is from a paper, Microbiome Science Ethics. And give you a brief example on how microbial resistance and the antimicrobial genes antimicrobials transformed the practice of medicine, but their effectiveness was compromised by the emergence of antimicrobial resistance. AR can encode it in the ARG or antibiotic target mutations. Many studies have shown that ARG can circulate in hospitals, animal farms, sewage treatment plants, and other environments. This picture gave you the example that the medical waste from human can increase the diversity of ARG in the soil. Some antibiotic-resistant bacteria that contains ARG diffuse in the environment through surface runoff and groundwater, which can also turn to human and animals through drinking water, plants, and other food chain pathways. In addition, humans can also be exposed to ARG through the foods of animals, such as fermented milk and meat products. And also, actually, the human gut microbiome is a reservoir for antimicrobial resistance. The healthy gut microbiome is a stable, diverse community that provides important benefits to the host. But antibiotics use can perturb this ecosystem by damaging its taxonomic and functional composition, creating opportunity for pathogen colonization. The overarching goal of the antimicrobial stewardship is appropriate antibiotic prescribing that results in optimal clinical outcome, decreased antibiotic toxicity, and reduced numbers of MDRO. But based on the new knowledge generated from human microbiome, this has been proposed as a tool and a target in the effort to addressing AR, including strategies involving the manipulation of microbiome to deplete antibiotic resistance organisms to enhance immune responses to vaccines may prove valuable. For example, the FMT to treat C. diff infections. And next, I'm going to describe the intersection of microbiome science and AS and the ethics for the control of management of AR. There are a lot of considerations we need to take into account before we just implement the microbiome science. And the FMT has been proposed as a tool for AS programs. There are two primary goals for the AS programs: to reduce antibiotic use and prevent the MDRO. FMT has been proposed as a tool. Maintaining the body's healthy normal microbiota is recognized as an utilized mechanism to prevent the MDRO colonization. As of now, FMT is generally considered a standard of care only for the treatment of C. diff infection that do not respond to appropriate antibiotic therapy. So it's not a first line treatment, it's the second or third line treatment. FMT use as a tool for ASP would require expansion of the current clinical indications for transplant. And next, I'm going to introduce what is human microbiota. The new research has been revealed that the health and diversity of the gut microbiome and the overall health are very closely related. Humans are viewed as composites of human and microbiome cells. Actually, the microbiome, human microbiome is very complex, and there are dynamic communities composed mainly of bacteria, but also the protozoa, archaea, virus, and fungi that resides in and on different body niches, such as the oral cavity, throat, esophagus, stomach. Our gut microbiota contains tens of trillions of bacteria, it's actually 10 times more cells than in our body, and there are 150 times more genes than the human genome. In total, it can weigh up to 2 kilograms. It carries out a variety of very important functions, which are vital to our health and actually our very survival. Exploration of the human microbiome has become a reality due to the new tools being available, like, for example, like the powerful metagenomics, and this one, the new technologies. And this is a picture, this is a table from the article, The Ethics of FMT as a Tool for AS programs. There are core elements for ASP programs and the potential rule of ASP with an expanded clinical use case for FMT. For the last couple of years, because I had a project focused on the human microbiome science, so I published several papers on the ethics and the social aspect of fecal transplant. This is a very promising treatment modality. Among other interventions targeting the intestinal microbiota, the rationale behind FMT has been to introduce a complete, stable community of gut microorganisms to repair or replace the disrupted native microbiota. So in the past, historically, we try to identify the pathogen and we use antibiotics to eliminate it. But now it's a paradigm shift into introducing a well-functioning microorganisms system. There are multiple clinical trials that support FMT as a highly effective therapy for severe C. diff infection not cured by first-line antibiotics. And for vancomycin, very from new antibiotics, the effectiveness only ranged between 40 to 60, but FMT, the cure rates are generally around 80 to 90%. An increasing number of studies have investigated the wider application of FMT, showing it to be effective in treating other conditions such as IBD, IBS, obesity, and many others. So it's been argued the expansion of FMT would reduce antibiotic use at the population level and theoretically reduce the selection of MDRO. So there's also a lot of enthusiasm trying to advocate that FMT should be adopted as a first-line treatment for a series of GI diseases, gastroenterology diseases. And also because currently there's no effective way to eliminate MDRO colonization of the stool, and this can be a risk factor for future invasive infection. This would require fundamental change in current practice and recommendations and require additional evidence and clinical studies. And there has been increasing volume of studies suggesting that the FMT has huge potential to treat GI and some non-GI diseases. Actually, there are clinical trials using FMT to treat cardiovascular disease and neurological diseases like Parkinson syndrome. So it's been portrayed as a very successful story. FMT refers to infusion of a fecal suspension from a healthy individual into the GI tract of another person to help to re-establish the functioning microbiota system and cure specific disease through colonoscopy or the capsules now. It can be taken orally. Why it's become so popular? First, because it's effect very rapidly and it's low cost and not a lot of reports of serious adverse effect and minimal risk, and avoid exposure to antibiotics, establishment of balanced gut microbiota, and it's been widely perceived as natural and organic. I have done empirical studies, questionnaire studies among the Chinese gastroenterologists, and they all reported they believe this as a nature and organic, but I'm going to argue that it's not value-free terms. It's actually connotating it's better than antibiotics, but this belief might be premature. And the media coverage portray FMT as something very miracle. This is a comparison of pre-FMT and post-FMT, and there's a wide media enthusiasm from the patient groups and doctors and globally. One man's poop is another man's medicine. And this reads the sons Duke have cured the father's 8 years of diarrhea. So if you look at the history of FMTs, it can dating back to 1,700 years ago at Dongjing Dynasty. It's very historical. It's been recorded in the Chinese medicine practitioner Ge Hong in his handbook of prescriptions for emergencies. He used the suspension of this fecal stuff to treat people with serious diarrhea, and it's not called because people don't recognize as microbiota. It was recorded as yellow dragon soup, and you can also find it's been recorded in Li Shizhen's compound deal of materia medica. The methodology of FMT. At that time, when I was writing the paper, it's mainly the donors from family members or friends. But now, I know that in China, a lot of college students can become donors. There are also the age frame for that. Rigorous screening of pathogens and infections varying, and then preparation of FMT material and the root adverse events. At the moment, there has been some protocols for the preparation and the methodology, but there's no globally standardized protocols. It's not available. And I actually spent a week in Nanjing in the second affiliated hospital of Nanjing Medical University, because there's a gastroenterologist. He claimed that he has done the 80% of all the FMT in China. And this is FMT through anima. FMT is still an unproven and exploratory treatment. Its therapeutic mechanism is still unknown, and our understanding about the composition and types of gut microbiome is very limited. It's unknown what strategies should be employed to prepare the patients for transplantation. It's unknown what quantity and type of organism should be used and how the treatment might be delivered. It's a shotgun approach. There is a large discrepancy between the low-K technology used in this treatment and the sophisticated knowledge of the intestinal microbiome. Here, next, I'm going to examine some of the ethical issues. It's also raised philosophical issues on who are we, personal identity issues, risk and safety, privacy and confidentiality, commercialization and public health implications and hype. So the next arguments are basically derived from some of the publications I authored in the last couple of years. With the knowledge generated from human microbiome research, if we get to know that half of our genes are not Homo sapiens cells, what does it mean to be an individual human being? And human microbiome research, that microbiome co-evolved with human host genome, perhaps we need to reconsider our symbiotic microbiome as part of us, than part of the environment. And how stable and unique is an individual's microbiome, because we know it's being affected by the take of antibiotics. Is there a core microbiome for human beings or particular groups sharing specific commonalities? There are also studies comparing with the Caucasian people's gut microbiome and the Chinese gut microbiome. How permanent changes to the human microbiome might be, whether changes could be transmitted to the offspring. The single Homo sapiens is not, in fact, the real biological individual. We should think of human as super organism or a super ecosystem comprised of the human body plus the collection of the microbes that inhabit the human body. There are also the statement being raised in this aspect. Our coexistence with the microbiome tells us that human evolution is not just human history, and Nobel laureate believed the combined human microbiome self is more dynamic and more interactive than we are used to think of ourselves as beings. And our human cells is actually only this little, and the rest are all microbiome cells. And in terms of genes, there are only this very little of human genes, and the rest are all the microbiome genes. So we are actually more microbes than man. Our microbiome determines ourselves. Should we be tailoring treatment to both our human and microbiome cells? There are also risks and safety issues about FMT. The first is that the stool is not a uniform product, it's not a drug, and clinical outcomes may depend on the donor. While healthy stool contains fewer ARG than patients who have received multiple courses of antibiotics, the number is not zero. And the recent study documents transmission of ARG from the donor to the FMT recipient. But there are many areas lack of evidence. A recent US FDA safety alert reported invasive disease in 2 adults, including 1 death, as a result of an MDRO infection about FMT from the same donor. So there are clinical risks, and there are also social and legal risks, because everybody has their own very unique personalized microbiome fingerprints. So it raises the privacy concerns. And there are also mental and psychological risks, because research has found out that some of the microbes is related to our mood, emotions, and so the transmission of the fecal microbiota may cause personality alterations and the potential transmission of anxiety and depression. And whether and how to extend screening programs in order to mitigate these risks, 3 questions can be raised. The first, whether FMT donors should be screened not only for pathogens, but for history of psychiatric and psychological illnesses, mood disorders. Second, by manipulating the gut microbiota, FMT could be used as a way to affect the brain and consequently scalping behavior. Thirdly, by transferring mood-altering microbes, FMT carry the possibility of altering a person's personality and identity. So our current categorization of FMT as something natural and organic and therefore safer may be premature and naive. There are also the research area in the gut-brain axis is exploding. A lot of research suggesting that there are interactive relationship between the central nervous system and the gut. So therefore, the gut has been called the second brain. And the study is suggesting that the microbiome transplant research in mice models, which show gut microbiota influencing stress and anxiety-related behaviors, germ-free mice with depression microbiota from human patients with major depressive disorder resulted in a depressive-like behaviors. These studies raise the question whether FMT alter the neurological state of the recipient. There are also privacy concerns because personal microbiome contains enough distinguishing features to identify an individual over time. So, and the changes in the microbiome could also be indicative of past behavior. For example, travel to a particular region could change a person microbiome by introducing new bacteria unique to a specific place, and also the sexual behavior, whether homosexual activities or the heterosexual activities. So this information might be of interest to particular groups like the Homeland Security people. It might also be possible to identify ethnicity, race, socio-economic background and nationality by analyzing samples of someone's microbiome. There is still lack of scientific consensus on whether human microbiome data is uniquely identifying human genetic data. And also, over time, microbiome can be easily affected by changes in diet, lifestyle, medication, time, and environmental factors. It's been also highly possible that information generated from an individual's microbiome profile at a specific time is not identifying at a later time. So when a human microbiome file is mixed with human genetic and other types of information, this could generate unprecedented personal revealing information of a new magnitude, travel experience, sexual behavior, and consumption of alcohol and drugs. This information could be of particular interest in forensic medicine or law enforcement. So we should advocate a precautionary approach towards the validity of any conclusions regarding undisclosed identification of individuals or links to disorders. Human microbiome research may raise concerns about the possible social stigma, discrimination, stereotyping, and abuse of information against certain groups. Protection should be provided for information arising from the microbiome banks. Our unique microbiome fingerprints, this new knowledge has already been employed in forensic medicine. There are also commercialization of FMT. Property rights for can fecal microbiota be patented? Who owns your poop when there are like if you are a super donor and your microbiome profile might be very valuable and could generate a huge profit. How should we think about ownership and property rights relating to various aspects of FMT? There are also concerns related to direct-to-consumer of FMT because there are already some posting on the internet and do-it-yourself home protocols. So some patient has been tempted to use it at home in the kitchen, use the blender, mixer to prepare the microbiome suspension. So this provides an opportunity to exploit patients rather than empowering them and give consumers the false impression that a quick fix can undo poor lifestyle decisions. There are also public health implications. From a public health perspective, antibiotic use could be avoided if FMT were used as an earlier intervention rather than as a last resort. Secondly, growing evidence confirms the shared nature of human gut microbiome across families and communities. Human microbiome can be transferred to others through vertical and horizontal pathways such as birth modes, diet, and lifestyles. There are research also comparing with children born through C-section and children born naturally, and it's been found out that the microbiome in the baby's gut would be very different in different birth methods. So the microbiome can be transferred from the mothers. In Chinese, we call not only 血脉 blood, also 菌脉. If evidence emerges of significant effects in this regard, the notion of an obligation to our common microbiome environment and the stewardship of the shared microbiome could be useful for guiding policy decisions on FMT. There are also hype in microbiome science, hype in the industrial, and the increasing volume study have found a wide variety of diseases associated with changes in the human microbiome, in particular the gut. These findings are often misrepresented and misinterpreted by popular science as exciting and attractive, which create excitement and enthusiasm among the general public. People are led to believe that microbiome is connected to all human organs and diseases, as well as high expectations that knowledge of microbiome will solve all medical problems. So there are companies often personalize analysis of microbiome content of fecal sample, promising consumer enlightening information and provide targeted diet and nutritional product, the commercialization of the scientific value of good bacteria, and some pharmaceutical companies may cite these findings and claim health benefits, even though their commercial products may not have the same strengths and the formulations as those tested in the studies. There are also hype in scientific research. It's important to separate hype from hope and health, but it's not always easy because there are also the scientific papers, there are hype embedded. So a paper published on Nature in 2014 has encouraged scientists to ask 5 crucial questions. Can experiments detect differences that matter? Does the study show causation or just the correlation? What is the mechanism? How much do experiments reflect reality? Could anything else explain the results? The scholar also reminded the history of science is replete with examples of exciting new fields that promise the gold rush of medicine and health insights, but require skepticism and years of slogging to deliver. Hype is dangerous. These are the articles are published on the hype issues, and also the questionnaire empirical study I did with the Chinese clinicians. There are also oral biome transplant. And I also interviewed with the donors' experience and their attitudes of FMT. There are also enthusiasm in pursuing a healthy, perfect microbiome, but it's entirely possible that there is no healthy microbiome, or perhaps there are many healthy microbes. But the microbiome is complex, varied, and ever-changing and context dependent. Healthy microbiome can easily turn bad, and unhealthy microbe can be normal, even necessary. Enthusiasm for manipulating microbiome because it's perceived microbiome could theoretically be altered through probiotics. So it's been called the only organ that can be replaced without surgery. But this quest for healthy microbiome has led people to take measures that are far more extreme than simply taking yogurt. So I'm going to argue that the dichotomy of good and bad microbes is stereotypical and need to be changed. Some promising probiotics may have unanticipated side effects for particular groups, while traditionally perceived harmful microbes have been found to have novel and potentially unanticipated benefits. So whether a microbe is helpful or harmful is highly dependent on complex host and microbiome factors. We need to be cautious with microbiome manipulation interventions on their broad effects on the host beyond the conditions they are designed to treat. Next, I'm going to conclude with there are many considerations when evaluating FMT as a tool for ASP to reduce antibiotic use and MDRO colonization. Although some considerations are currently hypothetical, but as human microbiome research progresses, this question may become increasingly salient. Desperation of the patient should never be the reason to treat with FMT. And the interest and the vulnerability of the patient should always be the paramount concern. This discussion has important implications for microbiome research and future microbiome-based treatment. We have to proceed with caution in any of the microbiome intervention involving introduction or removal of bacteria, especially we don't know the long-term impact. At the point, there's enough data for ASP to adequately support FMT for recurrent C. diff infection, but ASP should restrict the use of FMT to structured research protocol that will improve general knowledge of the risk and the benefit until more data has been published. And lastly, I want to introduce the new area of microbiome ethics. This box is from the paper Microbiome Ethics. And I think the first 3 guiding principles is strongly related to our One Health initiative. And I think there are a lot of research need to be done on whether microbiome ethics constitute as part of within bioethics, or is it more related with environmental ethics, Yeah, I think it's going to be a very interesting direction. Thank you very much. That's everything from me.
Yeah, thank you so much, Professor Ma. I'm afraid we're at time. Thank you, thank you. Yeah, so I think it's wonderful to use that as a way of thinking about how microbes are represented, because our next speaker, Dr. Elyssa Liu, she's going to present a different way of thinking about microbes. In fact, quite a big contrast with what we've heard from Yonghui about. So of course, there we're thinking about within a surveillance kind of setup, and perhaps the use of the term pathogen will point us in a particular direction. So with this, Elyssa, welcome. So Elyssa is with Duke-NUS, working with Professor Paul Prunick and team, which has done some very wonderful work on capacity building relating to surveillance. So Elyssa, feel free to comment on what Nic has spoken on. I don't know to what extent you look at non-human, but well, any thoughts would be brilliant. Thanks so much.
Sure, thank you. And my apologies, and also thank you in advance for your patience. As you can tell, I'm a bit sick. I'm recovering, but I think Hong Kong is a great place to be because it is the land of
Good microbes.
yes, and the land of great soup, great congee. So thank you for hosting me and for healing me as well. So my name is Elyssa Liu. I'm a legal and regulatory specialist at the Center for Outbreak Preparedness at Duke-NUS Medical School. I did just join recently, about 3 months ago, and in my past life, I was working at the WHO on health law and ethics, and also at UNICEF on health and emergencies and humanitarian settings. And interestingly, I was also one of the first people to co-lead the development of UNICEF's internal strategy on AMR, before AMR was even funded as a formal work area. So it's really nice to be here and hear all these conversations that I, was trying to start. So I am a lawyer by training. I focused on medical jurisprudence, bioethics, and then I did a master's in global health law. Oh, sorry, wrong screen. So a little bit about pathogen genomics. As you know, COVID-19 has resulted in millions of infections and deaths. However, COVID is just one of the many, many pathogens that contribute to epidemic and pandemic disease. We have SARS, MERS, swine origin H1N1, Ebola, and Zika, and they've all caused large outbreaks in the past 2 decades. But the COVID-19 pandemic has also generated unprecedented scientific and technological advances. So with pathogen genomic surveillance, it has transformed our ability to detect, identify the origins of a disease, and also respond to outbreaks. So for example, the SARS-CoV-2 viral genome sequence was shared just within weeks of the initial cases being detected. And using this genetic information, high-quality diagnostic tests were developed and designed within just months. We want this to be faster, but it's still, quite an achievement already. Highly effective vaccines were then designed, tested, and then deployed at scale within a year. Again, we want this to be faster, and we will make that happen. Advances in therapeutics and vaccine manufacturing, both of which rely on genomic data, have greatly compressed the time horizons required to develop and manufacture new vaccines. And then also with data sharing mechanisms, which we've heard about today and we'll hear about more tomorrow. It has also catalyzed an unprecedented rise in the availability of real-time virus genomes, which act as an early warning system for countries across the region. But then despite these innovations and their potential to both facilitate cross-country collaboration and equip national outbreak toolkits, the capacity to detect and respond to emerging threats across Asia remains a bit limited. So at Duke-NUS, we focus on Asia, but also Asia is the region of the world with the highest risk of emerging infectious disease outbreaks. So we have increasingly high population density and human mobility. We have abundant wildlife and very frequent human-animal interactions, climate stress, rapidly changing environment, and they're all shaping new patterns in human-animal interaction. So these factors contribute to increased outbreak risk by accelerating the spillover of pathogens between animals and humans and their rapid transmission. And we need more collective efforts to improve the preparedness there. While the utility of pathogen genomic sequencing in public health is well recognized, its application to infectious disease surveillance among many high-risk countries in Asia has been limited. In this region, during the COVID-19 pandemic, there was an upsurge in next-generation sequencing, or NGS capacity, and its utilization in responding to the pandemic. We'll explore this a little bit later on. So I wanted to go into just briefly on the link between pathogen genomics, AMR, and One Health, which many of you already know. So we know that pathogen genomics is a valuable tool implementing the One Health approach. It fosters collaboration across many different disciplines. We have disease surveillance and monitoring, where pathogen genomics enables the surveillance and monitoring of infectious diseases through different species ecosystems. And by analyzing the genetic makeup of pathogens in humans, animals, and the environment, we can identify the shared pathogens, trace and transmission routes, and understand the spread of diseases that affect multiple species, which is really useful during disease outbreaks. Pathogen genomics also helps in identifying and characterizing zoonotic pathogens and provides us with insight about how these diseases emerge and evolve and spread. We have environmental health. So pathogen genomics contributes to the understanding of the role of environmental factors. It also identifies and characterizes zoonotic pathogens there and how it interacts with environmental reservoirs and changes in ecosystems. AMR, pathogen genomics aids in tracking antimicrobial resistant pathogens in both human and animal populations, and it reveals shared resistant mechanisms and transmission pathways. And for policy development, the insights that come from our work will then inform public health interventions that both encompass human and animal health and creates a stronger case for One Health. The development of policies requires collaborative efforts, including a wide range of actors, as you all are. And then just a little bit into Asia PGI, because this is linked to the rest of the work we're doing on One Health AMR and pathogen genomics. So the Asia PGI, or Asian Pathogen Genomics Initiative, was established in 2021, very recently, and very timely as well, to leverage scientific and technical partnerships with the aim of accelerating the application of pathogen genomic sequencing to enhance outbreak preparedness and response capacity across Asia. So we have 4 main objectives that were just actually revised recently. One is early detection. So to establish Asia PGI Academy as a regional center of excellence for training and outreach to equip country teams with the latest advances in surveillance, pathogen genomics, bioinformatics, and data for decision-making. So Asia PGI Academy sits within Asia PGI, and it serves as a training hub for participants from low-resource countries in the area of genomic pathogen sequencing and surveillance. And the Academy aims to provide training in both lab bioinformatics capacities, and the training modules do take on a One Health approach with stackable modules in the focus areas of clinical surveillance, environmental, and animal surveillance. The Academy also coordinates with other well-known pathogen genomics training networks across the world to hold joint training in the Asian region. The Academy supports on-site cross-country learning, tailored country outreach by specialized teams, and also virtual learning platforms. And the first training session from Asia PGI Academy just happened in September this year and brought together 21 participants across 13 countries for a week at Duke-NUS to learn about the respiratory and novel pathogen detection. So this was in September. We have new tool development, which has the aim of linking genomic data to the development of diagnostics, therapeutics, and vaccines through linking scientists in partner countries to labs in Singapore and Duke-NUS Medical School, other partners in Singapore, local manufacturers, with the aim of regional self-sufficiency and commercial product generation. So Asia PGI has been working to develop sponsored short-term visiting scientist placements, which will provide opportunities for scientists from the region to work alongside labs in Singapore and undertake this kind of research. We have health system enhancement, which supports countries in integrating genomics into national strategic plans. So we're providing countries with direct country support here on pathogen prioritization, understanding the value proposition of genomics, and supporting the development of national investment cases. So the Asia PGI Strategy Think Tank aims to do this. And yeah, that's in progress. We'll go into that a little bit more later on. On enabling environment, we work with country partners to address cross-cutting implementation challenges related to emerging legal and regulatory frameworks. And this is the part that I lead. Federated strategies for data sharing, self-sovereign cloud computing, IP rights, market shaping efforts, and addressing supply chain bottlenecks. And this is with a bunch of different actors within Duke-NUS. So to go into this pillar a little bit more, the legal frameworks part, we're working with NUS, the Center for International Law, to respond to some critical legal questions that have emerged regarding the sharing and use of genomic data. And these are issues that we're covering during this conference as well. So these include benefit sharing, access, mechanisms to support national sovereignty for cloud computing and storage. We also work with the Center for Technology and Development within Duke-NUS on IP rights from products, including co-ownership of IP. We're also working with the Global Healthcare Innovation Alliance Accelerator, GHIAA, on developing legal resources for countries around contracts for global health products and bringing things from innovation to product. With PHAGE, the Public Health Alliance for Genetic Epidemiology, we're looking into data sharing, regulatory and licensing issues, and collaborating with them on that. At the same time, we're also working a little bit with private sector, so speaking to AWS, Google Health, Oracle, for example, on just cloud computing and storage, and bring that to countries. On regulatory system strengthening, we work mostly with the Duke-NUS Center for Regulatory Excellence, or CORE, so to build regulatory capacity, promote best practices, and foster global and regional collaboration. We also have a supply chain working group with 3 main goals: to generate market intelligence of supply side dynamics, develop tools and systems to understand demand, and establish a regional community of practice and foster that kind of learning. For the legal frameworks, we're also building a network. So if anyone is interested, please contact me later on. So moving on to one of the key products that we've had. Initial efforts from Asia PGI, we focused on conducting an assessment on the status of pathogen genomics capacity across 14 countries. So these countries are Bangladesh, Brunei, Cambodia, India, Indonesia, Laos, Malaysia, Myanmar, Nepal, Pakistan, Philippines, Sri Lanka, Thailand, and Vietnam. And we're hoping to do more in the future. And with this assessment, common challenges were identified, which then later informed the development of a regional roadmap that would assist countries in developing cost-efficient systems for pathogen genomics. So the assessment aimed to review current capacities and challenges related to the application of pathogen genomics and future preparedness. We reviewed global best practices and input from the Asia PGI reference group members, and documented, things from country partners, financing mechanisms, national policy contexts, data for decision-making, priority pathogens. And the roadmap, you can access it through the link here. I can also share a QR code at the end of this. Brought us with a few different findings. The findings suggest that all Asian countries are conducting in-country pathogen genomic sequencing with capacity extending across multiple sectors, including national public health labs and MPHLs, private and academic partners. Pathogens prioritized for genomic surveillance included SARS-CoV-2, tuberculosis, antimicrobial resistant bacteria, and influenza. Furthermore, let's see, sorry, next slide. We collaborated with about 42 different partners for this study from 14 different countries, like I mentioned, comprising 5 South Asian, 9 Southeast Asian, and our partner institutions include governments, academia, public and private labs, and NGOs. And the study was really insightful because they gave us a lot of country context as well, which you can read in the individual case studies on our website. Some of the recommendations are outlined here. We have financing. So there's a need for national investment cases for pathogen genomic surveillance. There's a need for global financing to prioritize early detection. Policy and guidelines, we need national surveillance plans that include pathogen genomics and multi-partner national coordination mechanisms. There were lots of issues around supply chain, and that's why we're forming a working group to address these more clearly. These are just a few outlined, but it's a whole work stream. So for supply chain, we have pooled procurement mechanisms for genomic surveillance commodities, regional supply chain solutions. For lab capacity, we have coordinated lab training hubs for novel and endemic pathogens and joint training for human-animal labs. Quality assurance and then bioinformatics and data sharing as well are very important. So some of the legal and ethical issues around pathogen genomics, and I have to thank the conference for making us brainstorm a bit about this, because we have been working on this, but we haven't quite framed it properly yet. I think the center is quite new and the legal pillar is also quite new. So this will definitely inform our work stream moving forward. We have been involved already in some of this thinking, but just to put it out is very useful. So some legal and ethical issues, as you've discussed and you're going to hear further in the conference as well. We have data collection. So these are some questions that might come up as you think about these. Let's see, data collection and then stigma and discrimination and data access and equity. So there are definitely disparities in resources, technology, and infrastructure for collecting, sharing, and analyzing pathogen genomics data. And the access to it might not be equitable across regions and countries. So for example, with SARS-CoV-2, we see that numerous high-income nations did not share demographic data with their international counterparts. And this inequity can affect the ability of certain regions or populations to benefit from advances and developing targeted treatments and vaccines. With data ownership and control, there are questions of who owns the data, who can access the data, who can use it. Are there any rights of the individuals the data is collected from? Ownership and control can be quite contentious. There are issues that may arise about who owns it, who can use it, and the rights of communities from which the samples are taken. Balancing the interests of researchers, institutions, communities, and commercial entities can be really complex and can lead to disputes over data control and benefit sharing. Pathogen genomic data often includes personal information about individuals or communities, and protecting privacy, ensuring confidentiality while sharing the sensitive information for research and public health purposes is crucial. Striking a balance between open data sharing and safeguarding privacy rights poses a huge challenge. And with equitable data access and sharing, I think to establish mechanisms for equitable data access and sharing is important, encourage open access policies for non-commercial data, and at the same time, we have to ensure that appropriate data protection is there and acknowledging contributions by data providers. We have to encourage collaboration between researchers and institutions and communities and facilitate fair data sharing practices. And I think with the development of new and more advanced data management and connectivity platforms like the cloud, we also need to consider the compliance with targeted privacy laws and standards that may be required. And with stigma, where is that? So there's one point on diversity and representation. We have to promote this by seeking representation from diverse populations and address any biases. There's also on benefit sharing, there's a growing demand for the development of best practices that would facilitate the sharing of open data, including metadata and anonymized personal data. We have to implement benefit sharing agreements that ensure equitable distribution of these benefits. And again, we have to ensure that communities contributing data receive fair and tangible benefits, such as access to treatments, for example, capacity building opportunities or healthcare improvements to just incentivize this. On data collection, we've heard a bit about the ethical considerations already, like informed consent, about maybe potential stigmatization of certain communities or regions based on genomic data. And we have to be quite careful about this. So I think we need to think about different kinds of data as well. So we have pathogen genomics sequencing data, but we also have personal data, epidemiological data, clinical data, metadata, and they're all required for this effective public health response. And without all this information, genomic sequences cannot be analyzed and interpreted correctly. We need all of that. And they all have different governing frameworks, I suppose. And genomic data on individuals may be private or sensitive because it includes information about the person's health, traits, and ancestry. And we know from previous research on infectious diseases, certain information can lead to stigma. So for example, with HIV/AIDS, there could be discrimination there depending on your country's, laws and things like that. And the ability to identify super spreaders then also raises legal liability concerns. We have to think about, how this affects privacy laws, which, or rather how privacy laws will affect this and what information can be gathered, shared, and used. Consequently, the sequencing, collection, storage, use, disclosure, and sharing of such personal data and information will be governed by general personal data protection or health privacy laws, as well as ethical guidelines. And with data sharing, it's a bit complicated because these laws vary by country. And then with international data sharing, it just becomes even more complex, right? So some states have passed laws that regulate the collection, storage, utilization, and sharing of human genomic data. And there may be regulations that differentiate between the use of genetic data for public health and then also for research. So we have to be quite clear about this and explore this in more detail. So some key questions include, for example, does the country have a law protecting personal data? What general or health privacy laws apply to genomic pathogen surveillance data, including metadata and other personally identifiable information? Are there any laws that govern the collection and use of human genomic data for the purposes of public health? Are there any special conditions attached to it? Does the law differentiate between data collected that is used for research and then used for public health? Which ethical standards apply? And then how is it made anonymous? And then are there any applicable EU or US privacy laws? So yeah, we know that we need clear frameworks for this, legal frameworks, but also ethical frameworks and guidelines. We have to develop and implement clear guidelines and frameworks that govern all this, and also include a respect for cultural values and at the same time promoting transparency and accountability. In thinking about collaboration among stakeholders, researchers, policymakers, and community leaders, an interesting point about involving communities, I suppose, which I think maybe we don't do as much as we should. They should be involved in the decision-making process regarding the collection, use, and sharing of pathogen genomic data, and ensure that they understand the purpose and the risks and the benefits of data sharing, and also respect the cultural perspectives and preferences. Transparency is, of course, important in all stages of data collection, analysis, and sharing. We have to ensure accountability by establishing mechanisms for monitoring compliance with the various ethical guidelines and address concerns and have an avenue for grievances and dispute resolution. And then data storage, that's, I think we're going to go into that a bit more tomorrow. But at Duke-NUS, we're partnering with a few private sector companies to understand this a bit more and understand a bit more about their scoping and present the various options, I suppose, to our countries. So as genomic surveillance widens its scope, the amount and complexity of data grows, requiring an advanced computing infrastructure for data capture. And consequently, there's a push from many experts for the creation of a cloud-based public health bioinformatics system. But from our work, we've noticed that numerous government agencies have either refrained from or shown reluctance in embracing cloud services, which hinders the adoption of cloud computing within the public health domain. Consequently, the development of a network for sharing data across stakeholders and borders faces many obstacles, as many states prefer retaining their data on site within their own national systems, instead of the cloud-based systems. So if a cloud-based system is eventually embraced, there definitely have to be adjustments in rules governing patient privacy and data security to accommodate these cloud computing standards as well. I think I will maybe just stop there. It's a very brief overview of the different issues we have been covering. Please direct any questions here to me or via email. And again, I've only been here for 3 months. I hope I tried to capture this the best I can, but if there are any questions I cannot answer, I'll definitely direct it to my team and get back to you. This QR code is just a link to our website. Feel free to scan it with your phone. We'll be uploading many more resources there soon, and there will be a legal page as well where you can delve more into the legal and bioethics issues. Yeah, and we'd be happy to connect. Yeah, thank you.
Thanks so much, Elyssa. Thank you. Hello, everyone. Welcome back. We're going to resume our session. So the next presenter is also an old friend, working very much in the animal domain. So I think it's wonderful that we get a somewhat different perspective on the subject. And I thought that it might be interesting, and this is something that perhaps we can have a discussion later on towards the end of this meeting. We do hope to have some kind of an output by way of publication from the meeting itself. Of course, there is a wide range of subjects being addressed, so I think it might be helpful for us to start thinking about the sort of angle that might be good to adopt. So this could be very much focused on very broadly data justice, but that might be a bit too abstract. The other approach might be to think about particular practices or elements. So Elyssa has very helpfully set out quite a number of issues that we could consider. Of course, data sharing is one of the very big topics right now. And there are different practices in place, depending on the sort of initiative that you work with, different domains, type of information, types of concerns. So that might yet be another avenue. So as we continue the day listening to different presentations, now shifting to perhaps a different domain, we might want to consider how all of these different discussions could intersect. So with this, Sesh, welcome. Sesh is very well known in the field, so I don't think I need to introduce him further. Yeah, you can see his... Well, no, absolutely not.
You're too kind.
The truth of the situation. So welcome, Sesh.
Thank you very much.
Have you been to Hong Kong? I'm sure you have.
Huh?
Have you been to Hong Kong? here.
Yes. I did
Fantastic.
several times. I was invited by Pasteur Institute for their courses. So
Right, yeah.
just,
So
over
you're
the-
familiar. So with
Yeah.
this, welcome, Sash, over to you.
Thank you very much. And thank you, Kelvin, for the invitation. I was very, very happy. You remember, I just say yes immediately. And I'm very happy to be there. Actually, yes, out of my field, which is quite interesting, just to learn a little bit out of your comfort zone, because I am totally out of my comfort zone with you. And what I would like to do here, because just to explain, for me, I'm a zoologist, ecologist by training, and I developed for now 15 years the investigation on biodiversity and health, and especially, of course, with emerging infectious disease, but not only, also antimicrobial resistance. So working really at this time on, I think starting, because in Thailand now more than 10 years, on beef, on continue also in the region. We have this new international research unit that joined the French CNRS, but the Cassetart Universities, Agriculture University, and the Maidol University, Science, but mostly with the Faculty of Tropical Medicine and Conservation Biology. So actually, this 10 years was already in One Health, because I'm a professor on the Faculty of Tropical Medicine and a professor on the Faculty of Veterinary Medicine. I'm not a vet, I'm not a physician, which is quite impossible to imagine that in France. But today I want to say first to give you also as I would say, data ecology scientist. So the first way to gather the data globally and to use this data to make questions, and after to go to the field and to gather data from the field, and after discussing all of these questions that we may have, and managing data, ethics, but also after to go back between the science policy dialogue, and I will explain a little bit with OLEP. We have already said. I'm very happy because most of you all these days put a lot of information already, so it's really great to go to this. But I will give you some quite important aspect to understand why we have problem with emerging disease and with antibiotic resistance. Because when you are looking at the data we can gather globally, as you've seen for the human health, with the number of outbreaks of zoonotic disease and the number of outbreaks of vector-borne disease, we are just on increasing number over the decades. And even we have a little decrease for some, but it's the same in terms of the livestock. So this is the livestock from the poultry for shorter period of time, 2005 to 2022, we have also an increased number of outbreaks in the livestock and poultry diseases, but also we have an increasing number of outbreaks of the wildlife on the same period by 3 times. And we all know that we have more and more species that are threatened by something that's happening to them that was not the case before. And on the top of this, and one of the major important factors, actually is not the wildlife, is the livestock. If we get now the data from FAO, the real data, you see the increasing number of animals on livestock on poultry. We have less than 1 billion of head cattle in 1960. Now we are more than 1.6 billion. Chicken, it was a little bit less than 4 billion. Now we are closing, we pass 30 billion, and we are reaching soon 40 billion. And the pigs also raise up to 1,500,000 after decrease because of this big African swine fever. What is the consequence? We should not say that is a planet dominated by humans, is a planet dominated by livestock and poultry. The biomass of the cattle on Earth is higher than the biomass of the humans. The biomass of all domestic and humans animals, including pets, actually is 98% of the total biomass of all vertebrates. And if you look at the number of animals, I told you the chicken, we passed the 30 billion, we are close to 40 billion. The estimation of the wild birds was 300 billion in 1997. It was estimated at 50 billion in 2020. Soon there will be more chicken on Earth than all the wild birds. So this is really the situation. And we are also in the planet really in the dung. When we look at all the data, when you see the amazing fecal excretion for all humans on their livestock is absolutely amazing, which cause a lot of problem in sanitary, of course, in pollution of soil, including, of course, of pollution, what we call the diarrhea that could happen everywhere with Cryptosporidium. We can have that in Europe, we can have that in Canada or the States, and we have also in developing countries. This, if we continue like this, more meat, less biodiversity, more antibiotics and biocides, we cannot do, we can do more. So, and we have now the more and more data with the global trends in antimicrobial use, or in food animals or everything, or in other, and especially, and we have this, and it was also linked with this trend that was very important, that was discussed this morning, the importance of the trends on the connections. And for example, the emergence of one plasmid mediated colistin resistant, the MRC1, actually emerged in China at the interface between the livestock. It was the surveillance that showed that in hospital, in the livestock, this was new. And very soon after, it's starting to spread all over the world. Actually, we were doing at the same time, 1 year or 2 years before, we were doing work on the antimicrobial resistance, showing also in Laos and in Thailand, looking at the spread between the chicken on the local peoples, the pigs on the local peoples. But we found after we replied, and we found already in a small village in Laos, this MRC1 was already there, even in a small village in Laos, and not only globally. So it was really this way that we are really on this antibiotic and pesticide superior, really looking at this Anthropocene, especially with this measured flow of everything all over the planet, including antimicrobial resistances, including, of course, pathogens that can make these outbreaks and pandemics. So that's why also that I told you that I work, starting to discuss, I was very interested by this way to why we lost biodiversity in the hotspot of biodiversity, why is also a hotspot of emerging disease, try to make this link between biodiversity conservation and social ecological dimension, try to gather more indisciplinary, I would say this. So that's why I asked Claire Lajoni to join also, and trying to understand this. So we did a lot of work on starting really by the locals. We did during 2008 to 2020, organized, now we can put more than close to 40 field trips now, because with this year, develop land use, working, we use rodents and rodent-borne disease, but why rodents? Rodents are everywhere. Rodents live with us on in these big cities with millennium. They are also domesticated in the crops also with 12,000 years, really at the starting of the domestication of plants, but also they move all over the world. So they are there, they are in the crop, and they are also in the forest or somewhere. Some are endangered, some are invasive. People are catching here, can eat also here. I eat some, there's very good recipes for rodents. I can say you this, and you can really work on. They are also very nice, beautiful animals, and very clever. That's why I was very interested by rodents. But finally, to understand more this rodent and rodent-borne disease, understand more how the rodents are using the landscape, are starting to be interesting by humans. And I found the humans quite interesting species, clever also, but actually I can say not so much as beautiful as a rat. But anyway, it's my opinion. So we work really on all of this. But what we did, we go there, we have the chance to work with a local, by chance, by colleague, with the local communities on administration, starting with, actually, it's 11 years this year, it was 10 years we worked there. And we have the chance to work with the local communities on all the local administrations, and is really on ecosystems, so place and with the lowland 4 village in the lowland intensive agriculture, passing really on this way of yes, intensive. And after we have 4 village more in the upland, close to the national farm, to national protected areas. So completely, even they're completely linked in the same administration structure with some of them the same dispensary, but they are actually free dispensary, but all with the same administration. And we just published just a couple of months ago, this way that to summarize this, we can say that it's like some kind of social ecological on One Health observatory, because it's 10 years of collaborative studies, where finally, step by step, we arrive to really to work all together to get actually the community engagement to formulate a problem. We arrive as scientists sometimes question arrive by the locals, sometimes it's arrived by the administration, try to develop the protocol design, the implementing design. With this, when you have all of this, you can go to the ethics and the permits. You can realize, analysis with data, all of data, I will show you. And after, this is something that is starting to be more difficult, communication, recommendation, translation, but to go back, of course, in a loop. So that's why first thing, it was really to describe the stakeholder networks. We were this and how it is organized, understanding what's going on. But after all of this, it was mostly, you see, data information, technical design. This is the two that are very important. And we developed several projects. So the idea was not to do all by yourself, but to attract other colleagues from, so we got people coming from Cambodia, from Laos, from Singapore, from Israel, from Japan. So many people working there with their own project, but trying to implement this. So we did rodent-borne, of course, zoonotic disease, and tick-borne disease, mosquito-borne, food-borne, expose them to pesticide. I will show you a little bit this, and up to also to the dog on community health, and something on the antimicrobial resistance. First thing, also really develop a land use, land cover, which was more by the remote sensing, but to go really working locally, especially with the people. So the agrarian diagnostic, the land use. So we have my colleague Bunsamai from Laos. It is a really good botanist on working there to make this, and some other colleagues that were doing all these soil water erosion that are linked all the villages, which can be a kind of basis. We did a lot of work on the animals, including of course rodents, but bats, fish, frogs, soundscape, also dogs, chickens, so many things. And we develop a lot of this. So just to show one kind of project, like foodborne disease, starting with this community engagement, starting to the protocol design, what is the technical design, all the ethical issues, realization, and after, finally, it was a food contest that was organized regarding the impact, the importance of this foodborne design. So going to the farm resist, is starting with some project with my colleague from Switzerland, from France, and also from Thailand. Some the different domains, mostly I would say the medical domain, but some like Anna Plieger from Switzerland was also the surveillance system, so mostly at the level of the livestock on public health. And there was this technical design to develop and genetics, so it was really to understand a little bit this flow of antimicrobial resistant genes, but at the interface of people, small and medium farm, pig farm, and chicken farm, but also we put also rodents. Of course, there is always rodents with me in everything. Also to see rodents that we trap really in the farms. And really at the very beginning, and to do, of course, all the genomics. So this is my work was really to help this implementation. So really to go to this. So I say that now every protocol, we have to publish the protocol before to get data. So which is really important to say that if we change something, we have to explain why we have changed the protocol on what is this. So really to be the more open as possible. And what we are doing, especially what's interesting in ethics in Thailand, when you touch at the ethics, you have also to see that how your study may also harm the community, not only the individuals, but harm the community. So, and it's a little starting also, a little also for the animal ethics. And this week, starting to discover, for me, because I was very much more interesting, how the people are doing their own pharmacopy on all of this. First, they have some farms like this that are like the farm exposition, like the farm model to see for the people. So there's absolutely no veterinary to come there, but explaining medium chicken farm, what you have to do, how to plant this, on the different type of molecules that you have to use on at what time of your growing rate of your chicken, including chicken vaccine. And we're starting also because I asked to take if the people were okay to discuss when we are doing the interview on taking the swab, because we are taking the swab of the chicken, we are taking the swab of the people, not by yourself, but we are taking some. Sorry, it was very funny, but before the dinner is more interesting, and we're starting to look at all these antibiotics, and this was completely amazing. Just put some that are little in the antibiotics on the. We have quite anything. You have sulfamet, moxifloxacin, betamycin, amoxicillin. Finally, this is a collection in the medium pig farm. You have all families of antibiotics there. They are there. So after how they get this, so it's also another story that we cannot do. How you can buy and you can find. So we were also very annoyed with this problem because actually it was not very well. We did not imagine this. And it was completely like the use of pesticide, because they are using the same thing for pesticide. This is something that we can go back to the communities with this. We can go back to the livestock locally, but we cannot, of course, really publish all of this data. It's too much. We put too much blame actually on the people. So I have another. We have a lot. And the other approach was there to when we work on this. And first, to have this approach of phenotyping, you cultivate, and of course you can cultivate only the bacteria that can grow on the medium, and you can see the level of resistance in the different, in the pig, the sheep, the chicken, the wild rodent, the pig farmer, the chicken farmer, and the non-farmer, of course. So you can see for different kinds, especially, of course, the one thing is the colistin resistance, because it's an antibiotic for safety, and it was in the public health we stopped to use this because it was too dangerous. But after starting to be when there was the spread on the increasing of the antibiotic resistance, we say, okay, we need this at the public health, we need this, and say that stop in the animal sector, stop to use this because we need this in the public health. And but the level, you see the level of resistance in terms of phenotyping was very nice. But after, of course, my colleagues were doing a real genotyping, complete. So there was about 1,000 full genome that were completely sequenced of different bacteria, really to better understand the ESBL producing for Escherichia coli, especially also all these colistin supported by plasmid in all of this, in all of this stuff. Just to briefly to what they've done, this is also the metagenomic, the genomic we see before. It's really all these putting all together, this annotation. So finally, you can do some structuration to find it's related together. And this is one part, the virologist. But after going to that, we say that who is sharing with what? Well, first, I was very happy. My favorite animals, which are rodents, were absolutely not really involved. Even we trap really inside the cage of the pigs or the chickens. So they were really completely outside. But you found, of course, and the humans were mostly together, but even they were located or associated between the animals. And so you have really two group of animal, pig farm or chicken farm, human that were also but connected by different kinds of sharing of genes. So mostly that actually the genes were all very rich in terms of very high diversity in terms of antimicrobial resistant genes, and especially in the medium farm. And this is quite interesting. So the medium farm is a place where the people starting small farm, it's more locally, medium farms is starting to be. I have to say also in terms of this, the big farm, which is CP most of the time, the big company, you cannot enter, you cannot say, you cannot do whatever. Even the livestock department, the animal less cannot go enter. So which means that our study target the medium farm and not the. Alors, this is one of things, and we did also some soil, because what I discussed about pesticide, we did also the same study with pesticide, exposure to pesticide, but this case it was directly the farmer that asked us, we use too much pesticide, is it bad for health? Wow. We say, very interesting, we can do that, but we are not from the agronomy sectors. We cannot provide any, we have to invite also people. And the livestock department also said that, wow, they use too much pesticides, is it bad for the production of the livestock? We did that. Why I put this data? Because it was listed with land use soil, and we put that also with the participatory mapping of this, because now we are more and more evidence that pesticide, like biocide, like also are also like a stressor, and may also have an impact in terms of antimicrobial resistance genes. Alors, what we found, we have just those people, is for you, is not still accepted, and it's just on the revision. But what we found that actually we did not find an increasing rate of antimicrobial resistance, but so not in terms of the evolutionary changes in the genes, but really a real increasing rate when there is exposure to glyphosate in terms of exchange of plasmid, which is also, you can put stress, you create something. We create something, but it could be affected because people are affected by the glyphosate. Animals are affected. We tested that. Even the dogs, and the dogs that are outside was very well concerned by the risk to exposure to glyphosate, and like also the cattle. So we were quite good. So just to go on for this, really we are still complaining. But what I put here also, what I presented before, is all this trace documentation. So we got to see as many things, data, pictures, maps, protocol, ethics, scientific report, data, whatever, on genetic data, biodiversity data. And actually, there is not so nice place to prepare like this of the environment. Some things are very sensitive because they were not very taken during a protocol. So it means that is related to what starting for me to be very important. So the ethics of field studies. So what we are doing when you are doing field work, and especially what are the impact of what we are doing in terms of field work, and especially just to say what happened after the avian flu crisis, the H5N1 in the management. The management, what was terrible, because there was millions of chicken that were killed in Southeast Asia. But what was the management after the crisis? After the crisis, the much day of the management was the killing of the backyard chickens, even if we don't have a real evidence that they were very important in the spread. They were maybe important in the contact between humans on the chicken, on the viruses, but not really sure in terms of the amplification. And all what was done, so killing of the backyard chicken, restocking only in favor really from the industrial breeds, and all the measures against traditional, like fighting cocks, everything. Finally, some data starting to show that there was a decrease of these indigenous chicken breeds diversity, not by the, what I'm doing. Yeah, because I put that all together. Not by the pathogen, but by the measure that was implemented after the crisis, which have the big effect to reinforce the concentration of the farm. And we go again in my first slide, we increase not only the number, but also the industrial farming, which with all the consequences, we have already a little bit. Alors, ethics of data, we'll not go a little more on this because we have discussed a lot of this morning. Very happy how to make a good data. We have several examples, including smart data presented Claire. We have the FAIR guide, so it was also presented this morning at the FAIR guiding principle. We have also, but we have seen very much a lot of also information, the ethics review for data intensive research. So there is another one, but there is a lot of this. But for me, it was also mostly to link when we work at the biodiversity on health and well-being, really working with humans, animals, plants, really to work and to consequence, not only in terms of legal ethics, but in terms also in terms of values and responsibilities that we have as a scientist. Alors, I would finish just with that because we discussed already with OLEP and what is OLEP? So it was much to inform you. Is the One Health high-level expert panel. So it was launched. It was decided in 2020 at the Paris Peace Forum, and really by supporting by France and Germany when the tripartite at this time, so maybe I make something bad here, and with the UNEP starting to pull this. So we are 26 members for many countries. Really, we have people, 2 persons from China also, and we have 2 wonderful co-chair. But we finish out the first mandate at the end of this month. So the 11th December will be our last meeting. What was we have to do, but you have seen already the definition to the WASTA's first definition of One Health, but you have already this definition of the One Health approach and more integrative, holistic. You have seen already this diagram, which means the One Health is no more at the intersection. The One Health is really at the integration and is really the 4 C's. Collaboration between sectors or disciplines, environment, coordination among societies at all levels, and within mind, the global health ethics, inclusivity, equity, and access. Capacity building, we discussed a lot of capacity building already, but really as a healthy ecosystem that are supporting healthy animals and healthy humans, and communication. So today we are communicate on this aspect. Accelerating One Health, now we have the One Health joint plan of action that has been launched on the 10th of December. Next week, you will have the implementation guide that will be launched, especially at the COP28, because the first time the health is putting really as a topic in the COP climate. And One Health as support for the One Health plan of actions. You see that you have still the action track 5, curbing the antimicrobial resistance. But we have also the emerging infection risk. We have all these health capacity, especially for the health systems. And you have also the communication, but you have the food safety. And I think the food safety is important in terms of the microbiota, what we discussed just before. And we have now the vector-borne and zoonotic disease stronghold that are this. And action track 6, for me, that is very important. The better integration of the environment into the One Health that are really theory of change already presented, but just that now we have finished the first round. We are waiting for the second round of expert. Just that the expert, I hope that we have. I was member to ask there will be law scientists and to be member of the OLEP because we did not have law scientists in this term, which was important. Everybody agreed. That's why it was really asking. And on this pathway, I would say that there are policy legislation, organization development. So, but this is the pathway 3 that are very much important. See, all these data, evidence, and knowledge will be really the role of the OLEP members for their next terms. And I thank you very much.
Thank you so much, Seth. Well, fascinating presentation to learn of all these developments, and glad to know that the rodents were not big contributors to the AMR challenge, as your research has found. It'll be wonderful to hear a bit more about the engagement with industry, because as you've mentioned, we can't get access to the huge agricultural kind of farms. So perhaps Chris might have some insights to share on that. He's going to share with us about agriculture and having access into that sort of practices. So so Chris Degeling joins us from Wollongong University in near, is it in Sydney or near Sydney? Near Sydney. Yeah. Thank you. Yeah. So he belongs to a brilliant team that's done a lot of work on public engagement. And I'm not sure if you're going to be discussing not so much that, a little bit, So we'll look forward to hearing about that. And of course, our big concern is basically with agriculture and how to engage, if this is even the right word for it. It's a huge challenge thinking about COVID for WHO. Well, certainly in another meeting that we've heard that where social listening is concerned, it's been immensely difficult to get participation from the social media platforms for public health purposes, particularly if they are primarily driven by commercial concerns. So, so with this, okay, thank you so much, Chris. Over to you.
So Calvin asked me to come and talk not so long ago, and one of the features of that is that I've actually sort of had to throw something together. So if it's incoherent or there are logical holes, I'd love to hear them, but I don't want to be punished for them. Thank you. The other thing to say is that I'm quite glad that I'm talking now, because a lot of the things that I want to talk about have been covered by other people already. So you have that moment where you go, oh, they're talking about that. And you go, oh, no, that's okay. It actually adds to what I'm saying. So I had a lot of that today as well. And I think, especially just following on from Serge and his lovely introduction to the way in which we are now turning into Planet Farm, essentially. So Planet Farm is a very different place to Planet Human, which is where we think we live. And it has lots of different implications and ways of thinking about how we engage in this enterprise called health. So we've seen various mandalas today about One Health and so on, and all of them are quite optimistic, and all of them have this sort of very, I guess you'd say, sort of biblical vision of how we might live in harmony with the world and other species. But unfortunately, if you look at the mandala, then all those sectors have quite deep traditions. They have quite institutional structures which are well formed. And when we ask for that sort of intersectoral integration that we are looking for, there are lots and lots of barriers and reasons why that integration won't necessarily happen in the way that we want to. So the introduction then of sort of the digital bit as well, I think, which pointed out very cleanly by Mike this morning, just creates a whole new raft of tensions and trade-offs and problems potentially. So I'm kind of like this curmudgeon who's going to start saying, oh, here are all these big problems. And you did that this morning, which was nice. So I don't feel like I'm the only one. So I'll just move on from there. So the first thing to point out, I guess, is that since we've kind of realized that there is such a thing as too much antibiotics, the cat was really out of the bag in terms of how we thought about antibiotics as a resource or a way to use it. So we've gone through this sort of period of quite liberal antibiotic use, and then we've ended up now in an area where we have too much antibiotic use, and we're doing all these different things to try and stop it. And we've now got this sort of sense of it's being, as it was spoken about by Isaac, as a common pool resource, which we need to protect and figure out ways to try and basically limit the amount of use using various types of mechanisms, which include stewardship programs and all sorts of other things. But as this has been happening in human medicine, and we've thought about this, antibiotics have also been part of, I guess, establishing various forms of what we might describe as political economy. And when I go to bioethics conferences and when I go to social science conferences, I get a lot of a political economy from social science conferences, but when I go to bioethics conferences, you don't see much political economy. And I always find that gap really frustrating and quite interesting at the same time. So by this idea of political economy, I mean that it's actually paying really close. I don't know why I've got that little, this is because I took stuff from Google, isn't it? And I just like, it puts up that little thing and says, oh, you cheek, yeah, all right. Now I realize what that's for. Okay, yeah, I can get rid of it. Okay, there we go. So when you talk about political economy, it actually points to the way in which structures and systems have legacies and impacts which have implications for what you might do in the future. So policy never starts with a clean slate. So when we talk about policy science interface, you've got an abundance of policies which are stacked up in the past, and you can't just sort of ignore them. You have to work with them in order to make change and do things. So if you start to think about political economy in terms of antimicrobial resistance, there are different political economies in the two fields that we're interested about, in One Health in particular, and livestock farming being the case example of where we should pay the most attention to how antibiotics are used in the animal sector. So in political economy and health, it's very much directed around provision of health care and the sort of the social or economic determinants of health. And the political economy of agriculture is really about maximizing productivity. And these are two fundamental different structures and two fundamental different goals. So if we think about, we have this global common good of trying to sustain antibiotic resistance, sorry, not to sustain it, to minimize it. If you're thinking about livestock as a place where you need to do this, it has a different founding mythology or a different problem set, which is what it's oriented towards, which has been this Malthusian catastrophe argument, which is basically underpins just about all agricultural practice since the 19th century, which is we have to learn how to feed many, many more people using as little resources as possible, or society is going to collapse. And this myth, or it's a common good, depending on how you want to think about it, is quite powerful, and it quite sustains and understands the political economy that I want to describe now. So I'm going to do a talk in bits, and I'm going to focus on two dimensions. The first one is the use of antibiotics as a means of maximizing agricultural output, what implications that has for what we might think about how we might govern antibiotic use in animal health, and particularly livestock farming in particular. And then I'm going to do a little bit more of a riff around what it means if you start to think about the digital revolution and the use of all these new technologies and these new ways of understanding relationships between things. And that's really around pathogenomics and the use of pathogenomics, pathogenic surveillance as a One Health tool. So as an intersectoral bridge that allows us to do action in human health and livestock farming for the benefit of both. And I'm going to point to some of the problems in more concrete examples that Mark was pointing to this morning. So the farming of agriculture, I don't know if any of you have read Klaus's book, but it's absolutely amazing. It's a good read in a bad way, or I don't know if you turn those two things around, you get the same sort of effect. But it basically points to the fact that the way in which our modern agricultural systems have been constructed and used, and the way in which we've maximized our intensive agricultural production, which is the idea of basically increasing the scale of farms and at the same time maximizing the output per unit on a farm, is we've relied on antibiotics to do a lot of the work. So antibiotics has come to act as an infrastructure, and by an antibiotic infrastructure, I mean that very literally. It's a thing that disappears into the background, but it actually supports the practice. In the same way, you drive across a bridge across the river, you don't really think about the bridge, you just drive across the river. When there's no bridge, it suddenly becomes very apparent there's no bloody infrastructure. So antibiotics have become embedded in our systems of agriculture in ways in which they've become invisible, and we've now got this countermanding force of using as little antibiotics as possible, which is butting very hard up against this tradition. So I think I've just made this point, but that's fine, I'll move on. Also to point out that we have other forms of antibiotic infrastructure which are used quite frequently, and they are problematic as well. We use it as a means to basically substitute for low access to low to high value medical care. We use antibiotics as a substitute for public infrastructure, and we actually use antibiotics as a means to replace labor. So in places like nursing homes, the way in which antibiotics are used is basically a direct substitute for care by a person most of the time, because we use it to cover up or just in case if someone has a disease or they're suspected. So we're very, very good at utilizing this resource in this way. So we explored this a little bit, a colleague and I, last year, doing a sort of series of interviews, and we interviewed veterinarians and farmers around antibiotic use. And we asked some really basic questions, and we basically came up, after following a bit of a regulatory analysis as well, and we found out that there was basically two kinds of policy landscapes that are operating around antimicrobial use and antimicrobial stewardship initiatives in Australian agriculture. And basically vets operate under a moral kind of structure in that there's something to be a virtuous vet, and to be a good vet is to use as little antibiotics as possible. So they get stewardship education, they have open access to antibiotics, but they're told it's bad to use some antibiotics if they don't have to. And if they fail in that task, and if they breach stewardship guidelines, essentially get a bit of a slap of the wrist. But their focus when they're thinking about AMR and antimicrobial stewardship impossible, is really trying to think of ways to minimize the use as possible. Whereas agriculture producers have different laws and different ways of being structured in terms of their antibiotic use. And so you have the medical side in which less is better. And then the agricultural side, it's actually they just want stable systems. So the antibiotics are basically an input into their system. It's something that they want to have reliable access to. The way in which they're taught about it is to basically try to minimize use through restructuring their system as best they can. And most people in Australia are doing that for the very reasons. And I think your guys' experiences you were describing earlier points to that. But the way in which they're framed is that they're actually not necessarily caring about antibiotic use for the sake of antibiotic use. Because there are now regulations around food standards and residue testing, they get penalized for the presence of antibiotics in their products. So antibiotics use is a risk to them that's a business risk. So they are oriented around that kind of goal as being a way to minimize use, whereas the veterinary side is basically much more framed around the moral arguments against that. And this has implications for the worlds in which they live in. So they have completing common goods. The vets really are focusing on governing system of AMRs around stewardship. The goal is to reduce antibiotics as little as possible with good welfare. And the compliance is maintained by the professional organisation through normative power and moral involvement. And they have basically their sense of responsibilities are oriented around it about maximising both human and animal health. Whereas the farmers, their systems and ways of thinking about antibiotic use is very much focused around antibiotic residue and not AMR. The goal is to reduce in the food system because it's a business risk, and the compliance is maintained around utilitarian power and calculative involvement. So basically there are monetary reasons for doing the right thing. And the responsibilities are not oriented explicitly around human health or minimising in the way that vets are, very much oriented around basically the viability of the farm, food safety, and maintaining animal welfare while doing all these things. So this has consequences for how antibiotics is used. You have basically two common goods and they kind of overlap, but then they're also in tension at various ways. And I'll talk about this a little bit further on the line. Now I'm going to talk about the second revolution, which is the datification bit, and going back to this founding myth. So agriculture has been using and increasingly collecting data for a very long time. And once again, concerns about how we might use this data are sort of coming in late and overlying over an existing kind of political economy. So most intensive systems, as I said, are now run in ways which are becoming increasingly integrated. They're becoming increasingly closed systems, and they're becoming increasingly corporatized and financialized, which means that the idea that you have one person responsible in a farm or that you have a system which is open to exploration is quite difficult because of the way in which corporations act. So Serge's experience of not being able to go and examine big farms in Thailand is not unusual because of the corporate interests that sit behind big farms are much more powerful and much more restrictive in what types of research are allowed. So with this kind of datification also becomes standardization. So data is power, and data forces you to do things, and data makes you standardize practice. So in broiler farms, you all end up with basically systems of inputs. And again, you had some lovely diagrams of all the different things that this is recipe for this, recipe for that. If you think about this in a global scale in a Western country with large industrial systems, there's not much choice or input. There's not decision-making going on here. It's a formula which is applied, and then the system is controlled to maintain the stasis of like the ability of the formula to function, which means that stewardship is out of the question. It actually becomes more of a business decision. So the types of things that you might think of with datification become less relevant to actually having power and the means to do anything. So this goes to the extreme. It's, you know, the way in which pork became a future commodity and financialized, and then drove basically the creation of massive pork industrial complexes in North America. If I can't recommend enough, Alex Blanchet's book, Porkopolis, if you want to see the future of agriculture and how scary it is. Yeah. But what that does is basically points to the creation of new forms of capital within these agricultural systems, which are incredibly powerful and are completely independent of any kind of normative force that medicine might have. So these competing common goods are not coming closer together in sense of a one health. There's kind of this fragmentation into a corporate well-being and a corporate understanding of what's needed, and then us kind of sitting over here pointing at stuff. And if we're not allowed, that's if we're allowed in to actually look at it. So what this means is you get this idea of a herd. Anyway, I've just said data is power, and I think I've made the point. But you get these really precise systems and herd health monitoring. So the individual doesn't become the focus of action. It's all about the herd, in the sense that you have not these sort of neat interactions between prescriber and animal. You have these interactions between trucks of drugs, suppliers, contracts, lack of agency. No one person is responsible. It becomes a very diffuse system in the way, which means that it's very difficult to govern from external sources or regulation. So with pathogenomics, you can do amazing things within systems to actually understand how pathogenness is moving with AMR around it. You can do all sorts of work, and you can do, commercial entities will often do this work for themselves, just because it's good for them to know how bugs are spreading within their own institutes and enterprises. But that doesn't necessarily mean they want to share it. And the reason why you don't get this type of surveillance, the more industrialized and intensified the systems become, is because there's no value add for the producers. Within the structure of the political economy of agriculture, there's no value in sharing this data for them at all. Why would they? Which creates massive problems if you want to have a one digital health, because most of the planet farm is commercially owned and increasingly maximally owned by large corporate entities. So we did some work, as I was speaking about earlier, where we talked to policymakers and public health practitioners and people who ran labs when pathogen genomics was just sort of becoming a thing about 10 years ago. And we had a case study in there based on the experience of one of the investigators, was that they were working with a company that was producing chicken wraps, and they could find that there was an outbreak from people who were eating these chicken wraps on an airline in Australia. I won't say which one, but it has a kangaroo somewhere in there. And they could identify that the pathogen was standardized across the people who had it just through this magical new technology called pathogen whole surveillance, whole pathogen genomic surveillance. But then when they want to actually go to the people who produced the chicken that was in these wraps, there was a shut door. And they basically entered into an argument about who owns pathogens, who actually owns a bug inside a factory. You can't get into the factory, there's no way of doing that at all. So you ended up into this whole sort of philosophical debate about what you do. So in any case, there was lots and lots. I can see from the graph there was a range of different opinions on how this should be managed. Incidentally to that, about 2 years later, there was a massive outbreak of, well, Salmonella infantis in the USA, which is now effectively spread throughout the US poultry industry. Causes up to 11,000 to 17,000 illnesses a year. The CDC can't do anything about it for this very reason. They can't get into the system. They don't, and the producers won't let them into the system because there's no reason for them to do so. So the way in which they're now managing this, even though it's causing significant illness, is basically trying to publish shame data around. So it's basically publicity campaigns which are anti-advertising against types of products, and they have to do this in a very careful legal frame because they don't want to, if they can't prove it, then they've got to be careful on how they say it publicly, obviously. So the follow-on story from that is in Australia in 2020, there was a outbreak of Salmonella enteritis, which actually caused enough significant illness in Australia to establish a monitoring system so they're able to act on the basis of a public health emergency. So you get those moments of crisis where things shift, and then the food industry has to respond because there's an outbreak and they can prove it. And now there's a surveillance system which is now set up across Australia for this particular bug. But if you want to have a surveillance system for pathogens which aren't necessarily known, then you've got nothing you can do. Again, the system closes down once more. So the point I guess I'm trying to make at the long run is that if you're asking these global companies which are operating towards a different logic and within a different political economy to participate in these systems, you need to find a reason for them to do it. Or you need to find compelling evidence of why they should do it. But to sort of march in and say One Health surveillance is going to be the thing of the future is not necessarily going to wash with the powerful interests and way in which it's organized currently. And it'll only really work if you can perhaps see it as a means for enhancing safety, but not as a means for policing industry. So what this all boils down to, I guess, is this idea of innovation and common goods, and we have this tension between these two things. And One Health doesn't really think about the agricultural perspective enough, I would say, or try and work with it enough. It's a real problem, both normatively and by it sounds like practically from what you're describing as well. In that light, recently we've done some consultation with Australians around the future of agriculture, and we've done this process which is called dialogue groups, which is sort of like a Socratic exercise in explaining. You use a scenario where you tweak little bits and then you flip the scenario on its end, and then people have to respond to that, and then you kind of get them to work their way through a moral playground. So the scenarios we were using was one of them was in horticulture with robot fruit picking, which obviously produces seasonal labor and changes the landscape because the way that will actually work forward. And the other one was actually increasingly intensified agriculture and the removal of humans from poultry farming, and the removal of humans from poultry farming systems. And the sort of disheartening thing, I think, and we're in Australia, like New Zealand, we have extensive farming. We don't have a lot of intensive farming systems yet, except for poultry and other ones, is that there's a real fatalism amongst publics. So for those of us who are looking for the public to help us, they've given up almost, to the extent that they no longer see that they have really a role in determining where their food comes from or how they're connected to it. They don't really have much understanding of the production flows, and we did have about half of our participants worked in agriculture, but even they didn't understand the political economy of what was operating around them in the way that we thought they would. And in terms of justifications for the types of intensification and that sort of mythology of we need to feed everybody, we did test the sort of sustainability arguments, food security arguments, and biosecurity arguments. And food security and biosecurity arguments around the need for these intensive systems were the strongest, and really the public does buy into the productivist logic which underlies all of it. So AI and automation, and I guess intensification, because that's what it's essentially going to lead to, was seen as being the ethical response to these emerging problems. And if you really push them hard, which I tried through various things to do, they end up trading human biosecurity for greater agricultural productivity. So what does this mean? I guess if you go back to the example of the stewardship, that you can have systems where even with these common goods that are in tension, you can get people to behave in ways where they kind of align. Even though they're doing it for different reasons, they end up doing the right thing most of the time. So that's okay, that's something you can do. So you can have these incongruence and types of power, which still means that you get the result that you want to through the actions of lower level participants. But underneath this is an unresolved crash of interests and values. And this can have a music effects and creates a lot of the politics that you see within One Health, which is essentially everybody's got a good reason for what they're doing, you don't understand. So that's kind of what you get. What does it mean about datification and AMR in agriculture? I think I'm of a view, having worked both in human health bioethics and in One Health ethics, and increasingly just sort of thinking about agriculture, the complexity of issues in agriculture is much greater than human health, because you're just not worried about the health of one population. You're worried about all sorts of different systems that interact in ways that are quite, as Mark pointed out this morning, it's just a web of trade-offs. So within how we sort of formulate our response, and when we're thinking about digitizing One Health, we've got to start to really think that there's a much greater range of values and tensions that are there that are characterized in the typical interactions that we think in, and use of data and use of antibiotics in human healthcare. And key to this, I think, is also thinking about those political economies and the intransigence of those to reforms that don't suit their interests. And I'll stop there.
Thank you very much. Well, certainly very engaging problems with, with no solution in view, I think it sounds that way. Happy now to be joined by Elyssa Liu. Professor Elyssa Liu is with our School of Biological Sciences. And she's going to continue to invite us to think about the intersection of things with a spillover of diseases. So Elyssa, welcome. We'll look forward to hearing your talk. Thank you.
Thank you. So it's great to be here today, and perfect timing following on from those two talks, because I will be touching on some of the elements that they came from. So first off, a little bit of an introduction to zoonoses and zoonotic risks, because obviously we need to have an understanding of just how significant a risk is presented by these. So there have been over 111 recent epidemic diseases which have a zoonotic origin. And in fact, 60% of emerging human disease have a zoonotic origin, with 72% of those coming directly from wildlife. And so we cannot underestimate the importance of understanding what spillover dynamics look like across these landscapes. And we've heard some of those themes being mentioned already, but it's absolutely crucial that we have a clearer understanding of the multitude of different elements that are going to drive the probability of spillover in these landscapes. Most human pathogens are also zoonotic. For example, 80% of viruses and a multitude of all of the other pathogens that we suffer. Now, in a One Health perspective, and I will come on to this more later, spillover happens because of a combination of different events that drives spillover. Understanding what those situations look like is essential if we are going to come up with ways to actually mitigate what those risks look like. And we talked about major events. Well, a global pandemic is kind of a major event. And I will be elaborating more on this later in the talk. But of course, understanding the risk of zoonotic pathogen spillover from the coronaviruses is also absolutely crucial. And we talked about earlier, one of the talks touched on Southeast Asia being a hotspot for these kinds of pathogens. Absolutely. It's also a hotspot of biodiversity and a hotspot of biodiversity loss. Some of the highest rates of deforestation in the tropics and the highest rates of mining, which means that we have the perfect storm of conditions that are likely to drive spillover co-occurring in this region. In terms of the coronaviruses, there have been 7 that are known to infect humans, and we know that with the beta coronaviruses in particular, we need to be very concerned. Now, beta coronaviruses have a number of things in common. One of them being that they are more often fatal to humans, and the other being that many of them are hosted by rhinolophid, the horseshoe bats. Now, this means that if we're going to understand what the spillover of these beta coronaviruses look like, and they do require an intermediate host, we need to understand more about the ecology of the rhinolophid bats that are normally the original reservoir host of these viruses. Because otherwise, when the next one does spill over, as it almost inevitable, it inevitably will, we will not be prepared. And I've had the assistance of senators literally messaging me about, why do we need biosurveillance? And my response is normally, well, do you have a safety belt in your car? We have precautions in place, so when an accident happens, we are prepared. If we do not have biosurveillance, we cannot prepare and we cannot manage what those risks look like. One Health means that we need to manage landscapes so we can minimize the risk. And that means that we are prepared for when it happens, but we also reduce the probability of it happening. And we know of over 200 novel coronaviruses in bats. Furthermore, we know that they have co-evolved with these viruses, meaning that they often will show no symptoms. We have people from Duke-NUS here. Duke-NUS has been leading on some of the research on just why bats are amazing. And just like Sergey loves rodents, I love bats. Bats are awesome and they make humans look pretty pathetic. So I won't go on to too much of a tangent on bats. You can ask me more over dinner, but a few, I regularly just talk about bats at dinners. That's what happens when you have a zoologist in the room. Just to put it in perspective, how fantastic bats are compared to an inferior mammal like, say, a human. A 5-gram bat can live 40 years in the wild, still be reproducing. Their telomeres often don't shorten as they age. As we get older and we downregulate one suite of genes and upregulate another, the bats do the opposite. Because a bat can't afford to get old. Because if you start falling apart like a human does, you're not going to be able to fly well. You need to be able to have rapid repair of tissues, because if you're flying around, you're going to damage your wings. But furthermore, a bat can accelerate its basal metabolic rate by about 16 times. Now, again, humans, pretty weak mammals. Our temperature goes up or down more than 10 degrees and we fry ourselves and die. You can't do that if you're a bat, because if you are flying at a high speed and your metabolism has to basically go into Ferrari mode, you're going to generate a lot of heat and a lot of oxygen radicals. And that means that as a consequence of this high selective pressure, bats have special DNA repair mechanisms, anti-cancer mechanisms, and they can often host viruses in their cells without showing any symptoms. Now, we co-occupy landscapes with species that have vastly advanced immune systems to us. That means we need to know how to manage these landscapes to reduce the risk of zoonotic spillover. I'll be coming more onto that later. So let's think about those preconditions for spillover. Now, of course, there's direct, there are indirect. So for example, if I go into a lovely cave full of Rosettus or Pteropus bats that have Marburg, it's literally going to be raining virus because there's a lot of viral pathogens that will be in their urine, etc. Those are going to be evaporating. We also have, of course, vector-borne diseases that are often spread by bites. And then we have water and foodborne diseases. So a good example of that is something like Hendra or Ebola. Now, of course, some will be in multiple categories like these, but we need to think about zoonotic spillover risk in landscapes looking something like this. So we have humans, we have wildlife, and we have livestock. And all of these are two-way pathways. We need to consider the interactions between every actor in the landscape because all of them play a role in spillover. And so bats have got a very bad rap, sadly. Everyone can agree that that's a terrifying animal. As I stated, they have incredible immune systems, and that means we need to have a much clearer understanding of what zoonotic spillover risk looks like in the landscape. One of the key drivers is, of course, unsustainable landscape management. Now, what unsustainable landscape management does is it stresses animals out. And of course, when we're stressed, we're much more likely to get sick. Many species will show a degree of immunosuppression, but also animals will have to move more to acquire resources, which means they expend more energy, but also they increase the interface with other species. So as we destroy a landscape, we add two of those co-pressures that are going to exacerbate the risk of spillover. We increase the interface they have with livestock or with humans, and we increase the amount of stress, which is likely to drive higher rates of viral shedding. And so health is a really good example of why intact ecosystems are critically important. And that means we need to understand what these spillover landscapes look like and understand why maintaining healthy, biodiverse, functional landscapes is crucially important to human health. So now staying with the example of agriculture and landscapes, and of course something that I grew up with in the UK, badgers and TB are a very good case study of why we not only need to understand what the interaction of agriculture and landscapes look like, but it's also a really good demonstration of the communication and the collaboration or lack thereof of governments with policy around One Health. So TB has been an issue in the UK since around the 1960s. Also, this was a time when maize production in the UK took off. Now, maize, very low nutritional content, very high in sugar. Badgers love eating it because it's like eating candy. But it's also not particularly healthy if you have a diet of junk food. And so there are some studies that suggest that it may have actually exacerbated their risk of carrying and spilling over TB. Now, badgers also have their lovely little badger latrines, so they will typically mark the edges of their territory and other parts by having toilets, which are often in the corners of fields. Studies, including by government scientists in the UK, showing that culling badgers will exacerbate the risk of TB because it will cause badgers to basically vacate areas and move more, which means that you get those stressed out animals potentially carrying TB spreading it to other areas. So government-funded studies showed that by culling badgers, you actually increase the amount of TB in the area around the cull zone. The government did actually ignore this because the current government wants the farmers' vote, and the farmers do not like badgers. And so, yeah, 130% increase in TB in the cull zones. This is a direct consequence of what happens when we perturb ecosystems. And it is also an illustration of the fact that we need to understand species ecology and ecophysiology if we are going to manage what these risk landscapes look like. So let's think more about these interactions. This is Congress Avenue Bridge in the United States, where they host literally millions of bats. Now, when the bats first moved in, there was public outcry. We'll all get sick. The bats will fly in and they'll get tangled in our hair and they'll bite us. Of course, none of that happened. Bats can actually, some species will eat 1.5% times their body weight per night in insects, including things like disease vectors, including mosquitoes. And they're now a tourist hotspot because people want to go and see this scene. And so whilst we can live alongside these species with little or no risk, we need to understand how to manage these landscapes so that we understand what these risks look like in these landscapes. So here is a landscape, and let's just think about how species are going to be interacting with this landscape. So of course, animals are going to be using different components of the landscape. Many bats will use linear features for migration. And that means that in different parts of this landscape, we are going to see different types of interaction. So in housing, we may have species that are roosting there, casts and caves, which have a huge rate of destruction in Southeast Asia. Again, critically important roosting sites. Species will be roosting alongside landstock, and they'll also be using linear features. So many bats in a landscape like this will only be restricted to that riverine area in the middle because many of them will only actually travel where there is dense vegetation. There's a whole lot of morphological details associated with that. So if I'm looking at a greater horseshoe bat, the only place that something like a greater horseshoe bat or most of the horseshoe bats will be is on this river in the middle because they are only going to fly along that densely vegetated area. That means that there are ways we can manage the landscape to minimize the interactions between different species purely by how we actually plant vegetation or fence off vegetation. This is all very manageable. Another example is something like Hendra. Now, Raina Plowright has done fantastic work at looking at the intersection of climate change. So when we have drought periods, for example, habitat destruction, and livestock. And so Hendra spills over into horses as a consequence of displacement of bats. So they've lost their traditional forest habitat. They're foraging in areas where there are horses because there are often mango trees planted for them to use as shade. And those horses get exposed to urine, etc. from the bats. Horses get Hendra and they spread it to the humans. This happens more when the bats are stressed out because of climate events, and it is a direct consequence of landscape change. That means once we understand that, we can reduce the risk by, say, not having a mango plantation in the middle of your horse paddock and making sure that elsewhere we have healthy roost sites so that the bats don't need to go into this area. Then we have manageable solutions based on managing what that landscape looks like. So understanding where that spillover risk may occur requires an understanding of both spatial and temporal dimensions. For example, understanding the breeding cycle of different species, because something like pregnancy is a huge ecophysiological stress. In fact, bats have the longest gestation and largest infant body size of up to 25% of the mother's weight. Now that's a huge stress. If the bat is pregnant and then she loses her roost because we destroy about 5.7% of casts in Southeast Asia every year, you're going to have a highly stressed animal forced to move elsewhere. And of course, that is going to dramatically increase the rate of viral shedding, and it's going to increase the risk. Now, if we then understand when the breeding period is and we stop mining during that period, you've already dramatically reduced what that risk looks like because you are not displacing an already stressed individual. And we know that during reproduction and lactation, the rate of viral shedding is higher. And so once again, by managing these risks, we can dramatically reduce the risk of spillover. So as I've noted, understanding the interface between zoonotic reservoirs like bats and understanding the degree of stress is important if we are going to manage these landscapes effectively. And the loss of habitat both stresses them out, which increases their rate of shedding of anything they have, but it also increases that interface. And so you are exponentially increasing what that risk looks like. And that means during key demographic periods, so breeding, migration, and hibernation, we know that these are going to be key times of the year that we need to be particularly careful about how we govern landscapes because it's when the risk is going to be highest. Furthermore, during climatic extreme events, we already have additional stress. We are forcing animals to move more because there are limited resources. And so these are also going to be key periods for making sure that species can access the resources they need, or making sure that they are less likely to encounter livestock or other animals that may present a risk. And so interventions need to explicitly reflect this. Fragmentation, of course, is associated with changes of diet, including changes in the microbiome, exposure to pesticides, herbicides, etc., which are also going to increase their risk, compromise their ability to combat anything they are exposed to. And so changing the landscape in this way has a domino effect by increasing the risk in many different ways at the same time. And we need to understand that in an area of the world that has some of the highest deforestation rates on the planet, we now have a perfect storm of preconditions for the spillover of yet more viruses with pandemic potential. And so understanding the links between species and species, as well as with the environment, are crucial if we are going to modify what this risk landscape looks like. Now, the good news is that we can intersect many different forms of data to understand what some of these risks look like. So this is a map of the fragment size of every intact landscape on the planet. And we can actually zoom in to a region like Southeast Asia. We can map out every forest fragment in the region. We can calculate their area. We can develop optimal ways for reconnecting them. And we can intersect it with other forms of data to help us manage what these landscapes look like. We can look at modifications like this. These are all elements of the human footprint, because Southeast Asia is one of the highest risk areas for zoonotic spillover. And so we can start to understand what some of these drivers of degradation look like. And we can look at where we have, and Sergey showed the same set of maps earlier, where we have livestock, where we have interactions between wildlife and livestock, and where we may get this combination of different risks occurring, because these things occur in synergy. We cannot continue to look at them in isolation. This requires co-designed solutions so we can maintain healthy environments, allow wild species to access the resources they need, and minimize the risk of spillover across landscapes. It also means we need to do things like map out where roads are. And it's also, as has been mentioned earlier, essential to recognize that many of the major zoonotic diseases are coming from livestock. But livestock are often acquiring these pathogens through exposure to wildlife. And that means we need to understand what all of the links in the chain look like. You can see many of the outliers there are bats and the rest are rodents. And so understanding where we get these preconditions are really important. So the continued loss of habitats will exacerbate the risks of spillover. While stopping further fragmentation is ideal, we know we will see continued development, particularly in high diversity regions across the world, meaning that we need to find ways to minimize that risk while still allowing sustainable development to take place. We also need to understand how we can integrate species ecology and ecophysiology into these approaches, and to understand what the dynamics of spillover look like. Now, part of that, these are rhinolophid bats, if you don't know what they look like. Yeah, interesting set of species. What you may not know is up to about 70% of these species in Southeast Asia have not been scientifically classified. And so some of the work we have been doing is trying to actually identify them, because if you don't know what the species interactions look like or where these species are, it's really difficult to do any other planning. So some of the work we've been doing has been mapping out their phylogenies, but also trying to understand what traits we can use to identify these species reliably in the field. So when we go to the field, we can actually see what species we have, rather than have to just use a genetic barcode later to work out what species it is, which is actually really hard, because even in databases like BOLDS, many of the species have been misidentified. And so assigning species correctly can still be really challenging. We can also understand what their distributions look like across landscapes. Now, when I showed you that map of the landscape earlier, and I said the rhinolophids are probably in that dense forest patch in the middle, well, that's because rhinolophids are photophobic. If you put a street light in the middle of the forest, as we did, the bats will avoid that area. And so that means that in your city landscape, where you have this beautiful walkway on the river with beautiful willow trees, if you put lights alongside it, you have already created a barrier to species navigating through that space. If they have no alternative, they will still go through it, but they will be very stressed, which means once again, we are putting another ecophysiological pressure on them, which is not good for us. And why, again, we need to co-design landscapes so we can minimize the amount of stress these species encounter and ensure that these landscapes remain permeable whilst minimizing the stress that species experience. Some work we did within Yunnan included understanding the bats and their coronaviruses. And we found that the bats in our institute had 24 different coronaviruses. This included several that were closely related to SARS-CoV and SARS-CoV-2. And one of those viruses even included a putative furin cleavage site, showing that this is not a distinct feature to COVID in humans. We are seeing it in wild species. Now, it's important to understand this in the context of the landscape, because what it showed is we found 24 coronaviruses in one bat community. These are not rare viruses. Spillover into humans is rare. And it highlights the fact that understanding what that risk landscape looks like is absolutely essential. Now, in order to map out what that risk landscape looks like, first we need to understand where the species are. Unfortunately, this is all data from the IUCN on amphibians, birds, mammals, the dragonflies, and the reptiles. I'm going to go fast because I know I've already been talking for too long. We see a variety of different inconsistent errors in all of these data sets. And so if you have seen maps of the distribution of spillover risk, they're almost certainly completely incorrect because they've been using these data sets. Now, here, this is the amphibians. In the amphibian data set, county boundaries were used in the US, but nowhere else. In B, the river basins were used for the dragonflies in the old world, but not the new world. In the reptiles, they used gridding of 1 or 1/2 degree grids. Every region and taxa has different methods. And that means for something like the bats, this is a biodiversity map for bats in Southeast Asia, according to the IUCN. Apparently in Xishangbane, we had 60 fewer species than in neighboring Laos and Myanmar. There were even studies that came out that said that COVID spilled over because this was an undercharacterized zoogeographic divide and that climate change completely changed the community, and that's why COVID spilled over. The reality is, of course, that's complete fiction. This is not a zoogeographic divide. This is a reflection of poor collaboration between the majority of Chinese researchers and Southeast Asian bat research groups, and there is no divide in species here, of course. But the fact that this has been a baseline map for many of the analyses that have been done of spillover risk highlights the fact that we need much better data if we are going to understand what genuine spillover risk looks like and manage these landscapes more effectively. And so something we have been doing, this is actually an older version, is developing a global bat database so that we can more accurately model species distributions. For example, here is one of our maps of old world bat diversity, and then we can understand what that spillover risk might look like across landscapes. And here is one for the rhinolophids, and you can see Southeast Asia is glowing with rhinolophids. It is the most diverse part of the world for these species, but for places like Indonesia and Papua New Guinea, we have insufficient data to do comparable analysis. Now, this is some work that my team did not do, but we are now trying to do for Southeast Asia. This is looking at the risk of the emergence of infectious epidemic diseases in Africa. We have been applying and are continuing to apply a similar but modified approach to Southeast Asia. And so on one side, you see the distribution of rhinolophid bats in Asia. And this is the fragmentation cross human population metric. And we are now working to intersect them so we understand what the risk of zoonotic spillover of coronaviruses may look like for the Southeast Asian region. And so in areas where we have particularly high levels of risk, we can first go to sample there to confirm whether or not that's accurate, but we can then provide guidance as of how to manage these areas to reduce what the risk of spillover looks like, because there are specific measures we can put in place to counteract that risk. And so in temperate regions, we know that bats are relatively well protected, but they are almost totally unprotected in tropical areas, and they are still commonly eaten. In fact, in rural Yunnan, even in the middle of the pandemic, people were still eating bats. And we know this because we would go and we would trap and we would find a net out which had freshly deceased bats in because they were still being consumed. Now, this is not something that should be stigmatized. This is something that happens in rural areas across the world. But when a tourist goes there who has no immunity, that is where a risk exists. And so we need to educate, we need to inform, and we need to protect species whilst also understanding that by perturbing species, we are also perturbing this risk landscape. So in addition to protecting key areas, we also need to prioritize sites, and we need to monitor what that risk looks like. This includes automated ways of monitoring, including doing biosurveillance, but also monitoring the presence of species, for example, using bioacoustics and combining this with deep learning to understand what species are present. We've also developed key methods for identifying priorities for caves worldwide. One of these includes a global database with more than 2,000 caves in, where we looked at the intersection of threat and biodiversity in different systems, so we can try to intervene in ways that maximize the conservation of these species, but can also be used to minimize where potential risks exist. Destroying habitat, as I've noted earlier, increases the interactions and the spillover opportunity. Loss of roosts will often force animals to aggregate in suboptimal sites or drive overcrowding. And of course, overcrowding is stressful. It creates novel interactions, and it itself is also highly problematic. Consumption of wildlife and the farming of wild species has also got an inherently high risk. And we also know that about 20% of bat species, over 250 species of bats, are still consumed. And when these animals are so good at hosting viruses, we also need to be aware that this is potentially not the best idea. Fur farms, especially where trafficking occurs, which is common in Asia, is also a very high risk. And I'll say a little bit more on that in the short amount of time I have available. Biosafety also needs to be improved. I think in every intervention we should not be assigning a moral judgment. We can't afford to assign moral judgments, and there is no place for them. What we can do is strive for better solutions that are informed by the science to mitigate what those risks look like. Now, I'm briefly going to recap some of the other issues with wildlife and non-wildlife, especially in the Asian region. So within Asia, wildlife consumption is now typically a luxury. It is done as a status symbol. It is done as a novelty. The situation in Africa is very different. Across Asia, it's easy to buy wildlife. Now, I've been a vegetarian since I was 3, but if I go to a restaurant in rural China and I look in the chiller cabinet for what I can eat, often you will find something like a squirrel or maybe a handful of bats that are available. Wildlife consumption is common and is normal in this region. But it does mean that we do need to conduct biosurveillance to understand when that risk landscape changes. Hunting is still very common across the whole of rural Asia. And in terms of species extinction, it's also high risk in some areas like islands. Now, captive wildlife is another issue which is commonly overlooked, but it's critical to understand. In the context of animals like civets, raccoon dogs, even small other mustelid species, within captive wildlife situations, including fur farms, you will typically have a mix of animals that have been captive bred and those that have been laundered and potentially trafficked from the wild. This means you have highly stressed animals that may have been exposed to all manner of pathogens in conditions with very poor biosafety where they are able to spread viruses to each other very easily. As part of major poverty alleviation strategies, these are major economic events across this region, particularly in parts of China where rural communities were often funded to create these captive wildlife farms. And unfortunately, new regulations do not close these loopholes because, especially in the context of fur farms, they were already only being produced for fur production and eaten occasionally opportunistically. This is going to continue to happen. Many species, as I noted, are still harvested from the wild, and there is a significant risk which is being overlooked in this industry. The same is true for fur farms, and the scale of this industry also requires careful examination, especially given that they often have poor or no biosafety standards, and as I noted earlier, often contain a mixture of wild-caught and captive individuals, which means we need to have much closer scrutiny in these farms if we are going to minimize the risk of diseases. In terms of biosafety, the unhygienic conditions, the modes of transport, the high levels of stress means that these are particularly dangerous situations in terms of the emergence of potentially new novel pandemics or epidemic diseases. There is no biosafety standards and very little regulation on them at the moment. In addition, as I noted, there is weak legislation and poor health, mixtures of diseases, and a huge interface between wild-caught and captive-bred animals, as well as having low regulations. And these are huge industries. They are valued in the billions, but we cannot afford to fail to regulate them if we are going to understand what these risk landscapes look like. Of course, livestock, impossible not to mention. The use of growth hormones and antibiotics also means that we have other novel issues that need to be considered. And of course, these are going to sap into wild systems and have untold effects in terms of future spillover. We also know that there are multiple other viruses, including those with pandemic potential, that are currently circulating. And so these are not minor issues, but understanding these in the landscape context is essential if we are going to understand what spillover risks look like. Furthermore, there is a major need for data. We lack data in many of these contexts. There is not a standardized data collection or sharing protocols, meaning that mapping what these risk landscapes look like remains tremendously challenging. Other work we are doing at the moment is trying to understand the roots. And so this is some work led by Jonathan Peckar that we are working on at the moment to try to understand the root behind COVID. But it is held back by the fact that we only have a limited handful of sites from native biosurveillance to actually understand where those risks exist and how we may circumvent future spillover events occurring. So in synthesis, understanding how species use landscapes, understanding ecology and species ecophysiology is crucial if we are going to mitigate risks into the future. We know that extensive landscape change will drive enhanced risk, and so we need to understand where these species are, how they respond to different forms of stress, and how we can manage these landscapes spatially and temporally. The difference between COVID and the literally hundreds of other novel zoonoses is a combination of different conditions and potentially the exposure of naive human populations to these pathogens. As we continue to develop this region, we will see this coalition of conditions occur time and time again, meaning that we need to act to understand what these risks look like and manage landscapes effectively. This will not be the last pandemic unless we learn how to manage what these risks look like. And so sustainability, including the tracking of wildlife and of livestock, is crucial if we're going to understand and halt these risks into the future. We also need standardization of all forms of data so we can use it better and more effectively so that we can manage these landscapes and the interactions of species that use them to mitigate what these risks look like. So with that, I'd like to thank you. I know I've used all my time, but please feel free to ask me any questions you may have later on. Shashmi.
Thank you. So on that note, I think we're at time. Thank you so much, Alice, for a brilliant talk. Thank you. So we're going to have a short break, and then we'll have two final presentations for today, bringing in the engagement element. So I think that will be a great way to end of the day just before dinner. So of course, we'll have more opportunity to interact. Hello, everyone. Sorry, welcome back. We are about to begin. It's wonderful that Alice did introduce the African context briefly, because in relation to bats. Now we're going back to the human domain. So we're going to hear from Dr. Edith Mandela Ntol. I'm sorry, I'm not saying this right, so you have to forgive me. Yeah, but I shall practice and do better. So it's wonderful that Edith has flown a long way to join us today, and we very much look forward to this perspective from Africa with some very important developments and lessons to share. Welcome, Edith. Very much looking forward to your talk. Thank you.
Thank you. Good afternoon, colleagues. At least I can say good afternoon. It's still the morning back at home. My own background is actually in mental health. I've got a PhD in mental health, but I work in the Department of Family Medicine with loads and loads of family physicians and many other professionals. As you know, family medicine is very much at the grassroots of medicine practice. So we also have a COPC research unit, which is community-oriented primary care unit, which is working very much at grassroots with communities. And a lot of my lessons then come from my longest experience, which has been in research management, but also regulatory issues in terms of human health and working with communities. So I'm the coordinator for the School of Medicine for Community Engagement. All right, so we're going to talk about data justice for human research participants because we're trying to shy away from the word subjects, which really treats them as objects. So, and this is a perspective from the African continent. That's going to be my outline. And I'm going to start with the term data revolution, which was first expressed by the UN in 2014, when they realized that data had become such a commodity and it was starting to rule a lot of what we were doing as humans and in every aspect of our lives. But what do they mean by data revolution? It was defined as the transformative actions that are needed to respond to the demands of complex development agendas, closing data gaps, building capacity and data literacy, modernizing systems of data collection and processing, liberating data from to promote transparency and accountability, and also to develop new targets and indicators. However, like any other revolution, we know that things can go wrong. Because once you've got a revolution, there are too many activities that go on, some not necessarily innocent, some not actually benefiting anybody, and especially some being harmful to other people or other organisms in the ecosystem. So that's why we come to the issue of data justice then, which has a premise that developments in data cannot be considered separately from social justice concerns and agendas, but they need to be integrated as part of them. And here we're talking principles of fairness, the principle of equity, ethical considerations in data collection, processing, and usage. And of course, we know that data sharing and its byproducts are critical for modern advancement in research in any field. And that translates to also economic development. But then the emphasis on transformative actions are required for data production, usage, and addressing societal demands. Now, that brings me to data justice and human participants. In terms of human participants, we're dealing with a very different species in terms of the ecosystem, because we're dealing with people that, we're dealing with a species that can very actively participate, unlike your environment and unlike your animals. They can participate to a point, but with humans, it's very different. So here, two aspects are very important. First of all, we need the oversight of the very participants in terms of perspectives in data justice discussions. And what do we mean by this? We mean that their voices, their concerns, and their rights must be very central to all of these discussions and decisions that we make around data. And these are the actions that we're proposing to be done. You must actively involve them. You must include them in the independent review boards and committees that are dealing with their data issues. The informed consent documents and procedures are very, very important. You must engage and empower them. I asked the question this morning, how do you ensure that the communities that you are dealing with are actually informed enough to make informed decisions. So you've got to empower them apart from engaging them. You've got to protect their privacy and their data. There has to be data security measures. There must be benefit sharing. You mustn't just come, collect the data and there's nothing in it for them and data is gone. Continuous feedback loops, I think someone did mention that. Education and capacity building. So we must capacitate them on an ongoing basis so that they should be active participants, but also informed participants. They should be able to ask questions. They should be able to demand answers and accountability in whatever is being done. And there must be transparency and accountability in the process. Secondly, we must consider diverse viewpoints in ethical data practices. What do we mean by this? We mean that you must take into account the cultural sensitivities and congruencies and contextual nuances. You must take into account diverse perspectives in decision-making. They mustn't be top-down decisions, but different perspectives, that work in a form of a matrix should come into play. We must consider the perspectives of vulnerable communities in particular and those who are marginalized. And we must be community-centered. So you must understand your community and you must make sure that whatever decisions are being taken, actually you zoom onto them and the decisions are relevant. But also there must be interdisciplinarity because this is one of the things that we learned in the space where we work, that as much as we are from a health perspective and we're coming there to offer health services, but we found huge environmental issues, pollution, scarcity of water, solid waste removal not happening. We found people were keeping animals, but not necessarily knowing what to do with the animals. Then there was a rabies outbreak and we had to mobilize other partners to actually come and intervene. And I guess that's what One Health demands, that you shouldn't just look at your working space from your one lens, from your silo lens. You must actually look at the community that you work with, whether it's animals or it's in the environment or it's humans. You must look at them with a very open lens that says, what are the needs here? So there are a couple of historical events that have led to the current ethical framework for human participants protection. And I won't dwell too much into them, but the first one is the Nuremberg Code, which resulted from the Nazi war crime trials, where the principle of informed consent had to come into play, whereby research subjects should be informed of the purpose of the study, their rights to decline participation, and any risks of harm to them. Otherwise, you're treating them as objects, not as human beings. The next one was the Tuskegee study of Black American men between 1932 and 1972 in the American South, whereby human participants who had syphilis were placed in a treatment or a control group without any knowledge of the study. They knew nothing. They were just classified, you go there, you go there. And the control group was not even given the treatment, even though it was known to be effective. So their rights were infringed upon. Then there was a Belmont report, which was produced by the National Commission for the Protection of Human Subjects of Biological and Behavioral Research in 1979. And this particular report laid a foundation for basic ethics in research studies as we know them today. And it emphasized three main principles. That is the principle of respect for the persons who are participating in research, the beneficence, in other words, there must be something in it for them. They must benefit from the exercise, and there must be justice. Now we're talking of data justice, but there must be justice from all perspectives, in all respects that you're dealing with these people. Now the Belmont report, ethical principles are generally accepted, and they are consistent with the United Nations Universal Declaration on Human Rights that was passed in 1948. And subsequently, we've had the Declaration of Helsinki, which is for medical research involving human subjects. I will say subjects because that's the title, that's what it says. But in my world, we talk of participants. So the Helsinki Principles for Research Using Human Subjects in Medical Research was actually designed by the World Medical Association. The first version was in 1964. And then it's been amended 7 times. And subsequently, it was aligned with the Belmont Report. And the most recent version is 2013. But more recently, there have been talks to actually come up with another version. So it's been translated into the 3 main languages, English, Spanish, French. And then there is a process that has been translating it into more other languages. But these are local medical associations in the different regions or countries that have done the translation. So I would dare this region to actually make sure there's a translation into Mandarin. Yeah. Okay, and the basic principles of the Declaration of Helsinki basically is respect for individuals, once again, the right to make informed decisions, and the recognition of vulnerable groups. Those are very, very core principles in terms of treating human subjects or participants. Now let's zoom into the African continent. Very big continent, divided into 55 countries. And these colors don't lie. And in fact, just because some colors have been repeated doesn't mean that those countries actually have a lot in common. It was just a matter of the colors ran out before the number of countries were enumerated. But we're talking about a continent that has a variety of differences from very, very different perspectives. And the number 55, as you know, there were 53 all along. And political events have led to a 54th country. And yet other political events have led to a 55th country. And who can tell how far this is going to go? And each time a new country mushrooms, it mushrooms with its own cultural nuances, with its own political nuances, with its own practices in every respect. But let's look at what these differences are. The African continent has unique social, cultural, economic, and historical dynamics as a continent. And I think it's very unique in this sense. It may have some commonalities with other developing regions, but probably not to the same extent. So we've got social cultural diversity, colonial influence and legacies, huge economic disparities between countries, but also within countries themselves, cultural heritage and traditions that shape identities and social structures in each country, within each country as well, and amongst the tribes, results of historical resilience and adaptation to past challenges, which are very different in different settings. We've got the urban-rural dynamics, which in most cases actually cause divisions on their own. And then we've got language and communication nuances. You know that the different languages in Africa are mainly English, Portuguese, French, and there's also quite a bit of Swahili. And in Western Africa, there's also what they call Hausa, which some people claim, or the West Africans claim has even a bigger portion than Swahili, which is, yeah. And that does cause quite a bit of competition as well. So there's acknowledgement of country-specific differences within the continent. And these, in terms of treating human participants, are very, very key. they're very important, and we advocate for them to be taken into account. But what are the challenges that are facing Africa? We've got multifaceted challenges, which include colonial legacies, economic disparities between countries and within regions, cultural diversity, and limited infrastructure, especially. And this gets even worse when it comes to research infrastructure, because as you know, in poorer countries, research is probably the least funded of all sectors. And when it comes to budget cuts, the cut starts with research, because unfortunately, most politicians don't see the value of research. And maybe it's our fault as scientists that we don't communicate the importance of research enough, and how it impacts development in countries. Now, African challenges related to data justice in particular. You again have colonial legacies, whereby there's exploitation of resources, there's imposition of Western-centric systems, and skewed power dynamics. In terms of economic disparities, you've got limited access to resources, unequal distribution of wealth, and disparities in technological infrastructure, especially. And then, of course, cultural diversity, whereby any research that's being done in a local community has to start by understanding the focus and the beliefs and what that community holds dear and the values. Otherwise, you miss the point. And if you don't engage the community, you even miss more of a point. Okay, let's come to issues faced by human participants generally. There's an issue of informed consent, which in most cases is because of limited understanding of research. We deal a lot with lay people, and you can expect that all participants will be well informed in terms of research procedures. So they've got to be informed of the procedures, the risks, the benefits, and what they are compromising by actually participating, and especially their freedom to disengage when they feel like. Lack of research infrastructure, I've spoken to this. Cultural issues, which may be very, very different in different communities, even within the same country, the same city. Socioeconomic factors like poverty, lack of access to healthcare, and limited infrastructure. And in fact, poverty does go a long way in that sometimes participants will participate simply because there's something they're gonna get in the form of compensation. And sometimes researchers are very guilty in this respect, in that they will use perverse incentives to get people to participate. So others participate because of lack of access to healthcare, and this research opportunity is the only opportunity they have to accessing a certain medication, otherwise it's beyond their reach. Health disparities. Due to high prevalence of infectious diseases that attack the most vulnerable, you may end up with only the vulnerable people actually participating in research, and the rest of the population, those who can go to private medical care facilities, not participating. There's also an issue of stigma and discrimination, whereby some research topics can be associated with stigma, and then you find that only certain people will participate, but others won't, because they don't want to be labeled. For instance, we in South Africa had quite a difficult time doing HIV studies, because even people who were HIV positive didn't want to participate in the studies, because the minute people see them participating in an HIV study, they would think, wow, they've got HIV. So, and we've moved a long way since then. There's been a lot of public education, and I must say we've tried to turn it around, but maybe we're not quite there yet. There are power imbalances as well, whereby partnerships with researchers from outside the continent come in and they don't understand the issues, and you find that African researchers do not feel empowered enough to actually veto what is coming with the funder, especially. There are data privacy and confidentiality issues where data of participants sometimes is not being treated as it should to afford them confidentiality and privacy. And they end up with data in the public domain when it shouldn't be. Instances of data extraction without knowledge, acknowledgement, or benefit sharing for participants, and this exacerbates the concern of exploitation, whereby the participants will then feel like they are being exploited in the process. So let's look at impact of data exploitation. There's no denying that data has become quite a commodity. And I've got a publication by Somnes and Company whereby they said data can be a source of economic efficiency and growth. This is both in a World Bank report, but also in the report of this data revolution organization of the UN. And the UN talks of the data economy, whereby data has become such an expensive commodity, but with also a lot of potential to be mishandled, to impose a lot of injustices, and also to be abused. So here we look at economic exploitation. African countries generate and contribute vast amounts of data through various sources. And data extraction from Africa without adequately compensation or involving the communities can exacerbate existing economic inequalities because you're just taking and you're not giving in return. There's also limited development opportunities if data is exploited and it doesn't benefit the people from whom it came. Because it's just not going to change policies. It's just not going to change the way people live. It's just not going to translate into advancement in development. Loss of control over cultural heritage. Africa is very rich in heritage, and data exploitation without proper community engagement and consent can result in the extraction and commoditization of cultural heritage, whereby people's indigenous knowledge systems, for instance, are taken away, and when they are used, they credit the people who have processed it rather than the people who actually originated it. Reinforcement of power balances can very much happen, whereby those who generated the data just take the data away and they feel more empowered. And those that the data was taken from are less empowered. They remain disempowered. Privacy and personal security risks, and also reinforcement of biases and discrimination, whereby which can be perpetuated against African communities if data collection processes are biased or discriminatory. And this can result in algorithms and technologies that reflect or amplify those biases, in fact. So let's look at how we can improve data justice. Of course, we need to promote fairness, equity, and empowerment in the collection, in the use, and governance of data. This calls for all stakeholders and role players to actually participate, because it can't just be done by scientists. It can't just be done by politicians. Actually, I wouldn't even trust politicians with any of this. It can't just be done by the communities on their own. And it definitely can't be done by funders, because sometimes they come with a certain agenda, and they get an innocent person who will do the research only to find that the intentions are actually completely different from what they understood. So we do need to promote fairness and equity and empowerment in terms of data handling. But what are the recommended strategies? And these strategies come mainly from our own practice where we work. And I'll just reiterate that they come from where we're doing research in communities. We're doing research in underserved communities, so in more vulnerable communities. Our biggest research projects are on implementation data, where we deliver health services and then we do implementation research in the process. And then also we have a longitudinal study that's collecting HDSS data, and we're collecting data from households and individuals. So there's a lot of community engagement that we have to do and get their participation. We work with the leaders, we have community dialogues, we develop flyers to inform the people. We make posters that we post at local shops and clinics and everywhere. Data sovereignty and ownership, the data that you collect from humans, participants belongs to them and nobody else. So we have to acknowledge that. Ethical data collection and use. Your ethics committees must kick in to make sure that all the practices are actually ethically correct. Capacity building and beneficiation. You must capacitate the communities. There must be some development that happens through your collecting data, and they must get some beneficiation in the process. Data governance and regulation. This is mainly from a government perspective. And as I said, I've been involved with a couple of regulation processes, like the clinical trials space. And there isn't much that communities can do if the government really doesn't strengthen this area. Bridging the digital divide so that people can have access to the digital data. Otherwise, only a few are gonna understand the data and be able to exploit it. Data localization and localization of expertise. We must make sure that data is protected at all costs. It's got a repository that is safe and that is secure. Access to that data is important. The usage of that data is very important. And then there's education and awareness, whereby communities themselves should understand why the data is being collected and how can it benefit them as well in the process, and where and how they can access it if they want to access that data, because it's their data, remember, so they should be able to access it. So in conclusion, data justice in the African continent necessitates a comprehensive approach that acknowledges and respects the unique perspectives of human participants. It requires ethical data practices, equitable representation, informed consent, and mechanisms for fair benefit sharing. It requires embracing the above principles. Embracing the above principles paves a path to fostering a data landscape in Africa that embodies justice, respect for individuals, contributes positively to societal development without perpetuating historical injustices. The path to data justice in Africa demands collaborative efforts by all role players, basically, policy interventions, and a commitment to ethical data practices, which in most cases are lacking, that empower and protect the rights of human participants. And it is also important to consider African perspectives in data justice for human participants. And really, I can't overemphasize that, because it's only by understanding the participants in context that we can do justice to the data that we get from them. Thank you very much.
Thank you so much, Edith. Wonderful introduction to a huge continent. So final presentation for the day, building on some of the points that Edith has shared with us. We do have Kalina with us. Kalina comes from even further away, Toronto, Canada, to be with us today. And she's going to speak to us on an important point. We've heard some wonderful insights from Edith on public participation in the research context. And in this particular connection, Kalina has done a lot of work. I don't quite recall when it was. I'm just trying to think. Kalina is an old friend, so with was it in Well, I don't know. Anyway, yeah,
2017?
probably. If that's considered, in any event, welcome, Kalina. Great to hear your presentation.
Thank you. Thank you. Thank you so much, Calvin, for the invite to give a talk at this exciting event. It's been a long day of multidisciplinary perspectives on data justice in antimicrobial resistance, in the development of initiatives for antimicrobial resistance that aim to mitigate certain risks and harms, and very interesting regional perspectives. And I think it's a little bit serendipitous that my talk is at the end, because I will talk about public engagement with data justice and embedding participatory governance into a one digital health framework to address antimicrobial resistance. And the topic of public engagement was already addressed by a number of speakers in the morning and in the afternoon session. And I think this provides a great opportunity to just really build on what the other speaker were discussing, different strategies for public engagement with data justice, different techniques, different frameworks for community engagement. And I'd like to circle back. There were several interesting perspectives that were provided in the morning, and I'd like to circle back first to the talk by Dr. Mike King and the discussion about social license as a problem for one digital health, and public. And one of the interesting point that you raised in your talk was about the fact that the social license may be difficult to achieve in Digital One Health due to its scale, due to a variety of stakeholders, the variety of technologies, and the epistemic uncertainty around it. And and public engagement is really very important in this process if we are really aiming to achieve this social license. Like if let's say, although there may be a growing pessimism that this is not possible due to the complex nature of the problem, public engagement is one way to really build this consensus around different intervention strategies. And that's why I think my talk is really provides this opportunity to address how various strategies for public engagement might actually contribute to efforts and to interventions and initiatives. And also, I'd like to circle back. There was a talk by Isaac in the morning about collective action and how series of collective actions may actually be very helpful in addressing problems related to antimicrobial resistance. And again, community engagement is essential in this process, especially if we are trying to link collective action with policy making and with science policy and governance. We do need to have effective strategies to engage different publics in the process. And after this like long introduction about how my talk is positioned within this larger discussion that we are having, so I will continue with my presentation. So in terms of the overview for the talk, so I plan to talk a little bit about public engagement more broadly, and just to address some conceptual and definitional issues regarding public engagement, especially since there seems to be a significant interest from advisory groups, from governments, from institutions in the domain of public health and One Health specifically, about engaging members of the public, engaging stakeholders in a meaningful way. So there are a variety of activities that are sometimes clustered under this broad term of public engagement. And there is general confusion. There is often a general confusion about the concept and what constitute genuine public engagement, what meets the normative criteria for effective public engagement, and how we can evaluate various activities. So I'll also talk about two different approaches to public to citizen engagement. With AMR and specifically the top-down versus bottom-up approach. And I hope also to outline or at least provide some suggestions about normative framework for public engagement in One Digital Health, just some considerations. This is a work in progress, of course. And I also talk about the benefits and challenges of using public deliberation in this context. And finally, I have a few remarks about participatory governance towards data justice and how participatory modeling can help us refine the concept and develop certain strategies. So conceptual and definitional issues. Well, you probably all are familiar with efforts to increase participation in decision-making or in research concerning One Health initiatives and other public health issues. And there's a lot of confusion about what public engagement is, what kind of activities are included in it. So I thought that it would be helpful to address some of these definitional issues, particularly because there are great discrepancies in terms of how public engagement activities are viewed in different jurisdictions and different scholarly environments. For example, in the UK, there's a strong emphasis on dialogical activity in science and technology policy, and it started in the late 90s, and then with the 2000 House of Lords report on science and technology policy, which discussed the appetite for dialogical activities. So we started to observe a dialogical turn in science and technology policy. But sometimes in the UK context, based on my observation, different types of activities such as consultations, surveys are designated as public engagement, but or a dialogue, but they're not actually dialogical in nature. They do not involve in two-way communication and interactions with the members of the public. So in order to overcome certain confusion, I would like to talk briefly about. Okay, so I wanted to talk a little bit about how we can develop a typology of public engagement activities. And this is one popular model, which is very frequently cited in the scholarship on public participation and public engagement. And this is the typology of public engagement mechanisms based on the directionality of information flow perspective. So it's a very popular article by Rowe in Frewer. So this model actually views public engagement as a more overarching term that encompasses three different types of activities: public communication, public consultation, and public participation. And the way these activities are described, they are grouped based on the flow of information and specifically how information flows from the sponsor of specific public engagement activities towards the general public. And as you can see in public communication, there's a one-directional flow of information from the sponsor of the initiative towards the members of the public. Public consultation involved has a different directionality of the flow. Here the sponsor of the engagement campaign approaches the public and solicit feedback. And then we have public participation, which is a more dialogical activity. It's more normatively a more desirable activity in terms of encouraging interactions between participants in the public engagement campaign and then the sponsoring organization. So I find this categorization particularly useful when designing public engagement activities that are aimed at specific policy impact. And it's a great way to develop specific public engagement designs. And I speak here from as someone who has been involved in the design and development of public deliberation events, where you are engaged in this technical work of building these public engagement initiatives, and it is very important in this case to really think about what level of engagement you would like to achieve with the specific event. So another way of developing a typology of public engagement activities is provided by the International Association of Public Participation Practitioners, and they have developed a spectrum of public participation, which emphasizes the public impact of every single participatory event. And the way they measure impact is in terms of the role of that the public plays in participatory events, and also in terms of the promise to the public that is made by institutions organizing these events. And the IAPT public participation spectrum looks at the increasing level of public impact. And you can see the variety of example of activities and example techniques that are included under the 5 levels of engagement. Campaigns that aim to inform the public, campaigns that aim to consult, involve citizens, collaborate, or empower. And the ultimate goal for public participation is to increase the level of the public impact and actually empower citizens by placing the final decision making in the hands of the public. And the promise to the public made in this case is that policymakers, decision makers will implement the recommendations of the citizens. And the most appropriate techniques to achieve this are citizens' juries, ballot initiatives, delegated decisions. So deliberative public engagement is is the one methodology that provides this greater level of engagement and empowerment of citizens. So I wanted also to talk, so in the context of engagement with antimicrobial resistance policies and also striving for greater benefits involving data sharing in this context. So I wanted to talk a little bit about top-down versus bottom-up citizen engagement, and just make a normative argument about the benefits involved with bottom-up citizen engagement and grassroots activism. And so the differences between these two approaches are often blurred, as sometimes top-down initiatives actually achieve the outcomes that are intended with the bottom-up approaches, but I just want to distinguish specifically in the context of antimicrobial resistance and then health initiatives. I just want to distinguish between these two approaches and emphasize why the bottom-up approach is more beneficial. So in terms of top-down approaches, where we have engagement usually implemented as part of a mandate associated with the worker-specific advisory bodies at the local, national, or global level, or with other decision-making bodies. This approach is very frequently seen as being deficient in terms of very often perceived as paternalistic. Like, for example, there are many criticisms of expert-driven initiatives used to inform the public, and the argument here is that we need to delegate decision-making to participants in the engagement process, not just simply inform or solicit feedbacks from citizens. So this is one of the major arguments that is being provided. Also, criticisms of the top-down approaches are based on the premise that AMR is a social issue that is largely driven by human behavior, and hence government should seek to address it through engaging communities to promote correct behaviors. So there is this understanding that the complexity of these social issues require something more than just commissioned initiatives to inform citizens to seek feedback from their own policy initiatives. And top-down approach also is not particularly effective in building trust and securing wider public acceptance of regulatory surveillance and monitoring interventions in the domain of One Health initiatives, and also in the AMR space specifically. So there is still like a growing gap between publics and decision makers, and top-down approaches cannot overcome this gap very easily. So in terms of bottom-up citizen engagement, and it's often seen as the normative standard for engaging members of the public in science and technology policy making. So some of the arguments here range from statement that it's better suited for the local context of antimicrobial use and abuse, that it can facilitate co-development of tailored solution to AMR. Mostly because bottom-up citizen engagement is more closely linked with grassroots activism, and it really involves like stepping in, going to the communities, working them directly on the design of specific policies, specific interventions. So it is viewed more favorably in terms of encouraging citizens to participate on an equal footing with experts and in the development of specific solutions. Also in the literature, bottom-up citizen engagement or community engagement is viewed very favorably, since there is a perception that it can allow to address many of the complex AMR-related inequalities in low and middle income countries. So it is an approach that allows to tailor the initiative specifically to the needs of these low resource settings and communities. Also, recent studies suggest that public engagement initiatives in such low resource settings that utilize a more contextualized approach to address the challenges of AMR and develop meaningful solutions for local communities may facilitate behavior change. So there was a lot of talk during the day about so how do we really on specific issues within the different domains of One Health. So how do we really modify established behaviors, that contribute to AMR? How do we really encourage, promote change, real change, like in real life situations? And bottom-up citizen engagement is one of those methodologies. And it was quite interesting when we discussed specific examples in this afternoon in livestock farming, and then community engagement in scientific activities. And I think this was a very good examples of how, you know, working with communities within the communities can provide an opportunity to develop meaningful solution at the local level. So normative framework for public engagement in One Digital Health framework. So when we think about developing certain solutions to encourage benefits associated with data sharing. So I was thinking about what would be the appropriate mechanisms, the appropriate techniques, and to engage citizens with the development of such equitable open sharing framework. And what should be the general approach in terms of engaging citizens? And as I have mentioned earlier, deliberative public engagement is often viewed as a superior approach in terms of engaging citizens to develop in initiatives that have tangible policy outcomes. So I would like here to propose using this methodology. And I am a strong advocate of deliberative public engagement. I really believe that it has transformative power. I really believe that it empowers citizens on a level that other type of engagement initiatives cannot achieve. So it's one of those. So first of all, a little bit about deliberative public engagement. It is viewed as and it has to do with the project of deliberative democracy, and it is viewed as an alternative of aggregate vote-centric perspectives of democracies, models of democratic participation. So deliberative public engagement really builds on the power of the community. It's characterized by representativeness. So it is representative of the diversity within a specific community. It is also so it also meets the criteria about inclusiveness, because it is an approach, public deliberation it is an approach that puts specific focus on engaging members of underrepresented groups in society. So practitioners, public participation practitioners, know about this methodology that usually when citizens are recruited, there's like different sampling techniques and methodologies, but in most cases, the emphasis is really to provide opportunities for the participation of minorities, underprivileged groups, and this is what makes the approach particularly valuable. It allows to overcome deficiencies in associated with representative democracy and decision-making in representative democracies. So it is one of those thick methods of public engagement. So we have here mechanisms such as forums such as citizens panel, citizens assembly, citizens juries. So these techniques allow for more meaningful engagement of citizens. They have a strong learning component. They also they encourage citizens to deliberate over shared values within the community, and then base decision making, identify shared values and base decision making on these values. So it also promotes direct involvement of citizens in decision making. So citizens juries usually are designed towards specific policy-related initiatives, and citizens develop a very focused recommendations on how to implement specific policies, and this makes the approach more effective. Not in all cases, there are methodological difficulties. There are also like obstacles in elected representatives may not agree with the decisions of the citizens. So it's not an approach that always has beneficial results, and it is an approach that is still experimental. It's developed in academic settings, and it involves like experimental designs, but it could be a very effective approach that engage an informed citizenry, and it is an approach that is oriented towards consensus and decisions that are acceptable to all participants. So some key considerations for adopting public deliberations, and when I was thinking, and again, this is a work in progress, but when I was thinking about adopting public deliberation in specifically in terms of digital, in terms of One Digital Health, so I came up with several ideas, and the first one is that we have to consider that public deliberation is likely to be more efficient when decision makers in the AMR globally, locally, and in the AMR global, local, and national policy arena understand the intrinsic value and benefits of this participatory approach. So there is a need to be done around about educating policymakers about the value of this public engagement initiative. So the success of every single engagement initiative really depends on how aware decision makers are, elected representatives or advisory body are about the benefits of this participatory approach. Then second, I was thinking that if if the scholarly community decides to pursue this venue of participatory governance, that a global approach would be more effective. For example, we may coordinate efforts in different jurisdictions to model, to develop deliberative events at the national level, and then exchange and then this coordinated approach could be further very useful in terms of developing, engaging communities globally. And I think a good model, good example for such an approach where you have like coordinated effort at different national levels is the Global Citizens Assembly on Genome Editing, which was convened by the Center for Deliberative Democracy and Global Governance at the University of Canberra, and it provides a very useful model for this. And I will go quickly, skip quickly through the benefits because I discussed them excessively, but I will just mention some challenges about if this is the approach we adopt to participatory governance. One of the challenges is, and it generally applies to public engagement in this sphere, is that there is a lack of consensus about whether public engagement can be successful in addressing KMR. So yes, it can raise awareness at the national level, at the local level, about problems, challenges associated with it, harms to public health, but raising awareness may not change behaviors and practices. So that's a key methodological issues. And then due to another challenge is that, you know, we have this, we have this very complex issue, and antimicrobial resistance that takes place, the developing of solutions to address it takes place in very specific local context. And there's some scholars claim that due to the language barriers and the limited methodological support for public engagement, it is currently underutilized within the AMI sphere. And there is a need to think more seriously about what type of approaches and design we can adopt to remedy this problem. And then just like this is my last slide, so in terms of embedding participatory governance we've been talking about this framework for data justice, for more inclusive, equitable benefit sharing in One Digital Health. And thinking about this participatory governance, like the scope and the possibilities, so just several considerations that I think are important. So the first one is the early engagement of communities to determine the key societal values for the deployment of digital technology. And that includes AI and big data analytics. The reason why I'm proposing this early engagement is that there seems to be greater focus on expert perspectives on how AI can benefit communities, and greater focus on perspectives and values identified by experts in preventive strategies and public health measures that target AMR. So I think it would be really important if we start this conversation about what are the values that and the benefits that members of the public view in adopting digital technologies. And also, I think it is important to think about embedding participatory modeling in research initiatives that aim to promote data sharing across key knowledge domains of One Health. So the impetus has to come from researchers, and thinking about how developing frameworks for data justice, so how we can embed participatory approaches in the research design and really engage citizens as co-producers of knowledge. And then there should be a greater emphasis on the co-production of research and outputs to develop that data-driven solutions to address AMR in the human-animal ecosystem interface. So this emphasis on really drawing on lay knowledge and embedding lay knowledge perspectives into our work as researchers. And one last idea that I thought about is that ensuring data justice is such an arduous task, and we are talking about it and all the challenges and methodological difficulties. So how to make One Digital Health initiatives more inclusive, more representative, how to develop benefits and benefits framework that will bring just solutions for everyone. And and the idea of using a global citizen forum for the development of One Digital Health framework may not be a bad idea, because it will really generate knowledge about community perspectives at the local and national level, and then bring this perspective to dialogue in the global policy arena. So with that, I will conclude because my time is up, and just want to thank you and provide a quick link to the Canadian Institute for Genomics, the website of the Canadian Institute for Genomics and Society. And the reason why I'm doing this, I want to invite you to just quickly look at it. And this is an initiative that I started myself, and it's an independent research institute that is not currently affiliated with any specific university or any specific granting organization. And I think, if we, and it will be interesting to just look at the type of work that we do specifically in terms of science communication and public engagement with genomics, with innovation and in genomic medicine. And it's a good example of a research think tank that originated at the grassroots level. So thank you all for the attention and for listening to this.
Okay, thank you so much, Kalina. I'm afraid that's all the time we have got today. We're going to continue the discussion for some aspects of it tomorrow. So let me thank everyone again